base excess?
Right. Base excess defines metabolic acidosis and metabolic alkalosis.
Okay. But there was another one too. I think it was called bicarbonate. Does that also help you determine metabolic acidosis?
The bicarbonate is helpful if you don't have a blood gas because you can get a measure of bicarbonate on a venous blood chemistry.
And there was one other way to measure or calculate bicarbonate, and that was through another reading that you could get on a different test. I think you said it, venous blood test.
No, the bicarbonate can be calculated. If you have both the PCO2 and the pH, you can calculate the base excess and the bicarbonate level.
Okay, but you can also use total CO2, isn't that right?
Total CO2 is a direct measurement on venous blood, usually.
Right, so in the venous blood test, you can use total CO2 to understand what's going on with the bicarbonate?
Right, because the difference between total CO2 and bicarbonate is in the second or third decimal point.
Okay, and critical levels of bicarbonate would be less than 20, is that right?
Less than what?
20?
Yes.
Okay, 19 or less?
19.
Yeah. Okay, Dr. Brown, I did want to hit, before we get into the case, you said something yesterday. We were talking about informed consent and what that meant. You said something about a physician could need to get informed consent, or a nurse could get informed consent. I think you said depending on what's going on.
Yes.
Are all types of nurses responsible for getting informed consent?
No.
Okay, what types of nurses are responsible for that?
So the two types that come to my mind would be nurse practitioners, and the other situation would be a nurse anesthetist.
Okay, and those are advanced practice nurses?
Yeah, they're CRNAs.
Got it.
And so they would be administering anesthesia. And if you're going to administer anesthesia, you need to get informed consent.
Got it. Okay. Got it. All right, now yesterday we talked about Grace's treatment at St. Elizabeth Hospital. We started off with the first overdose, October the 7th, right? That was the first one?
Yes.
Okay. And that one was with Precedex, is that right?
Yes.
Okay. And then we talked about the second overdose. That would have been the next day, right? October the 8th?
Yes.
Okay. And I think you said that that overdose was actually a near-death experience for Grace, is that right?
They both were.
They both were, okay. We talked about how on the 8th, Grace required resuscitation drugs.
8 hours.
8 hours of resuscitation drugs?
Yes.
In a central line to give those drugs?
Yes.
Okay. Okay, we're caught up. October 10th, 2021, so this is 2 days after the second overdose. Based on your review of the record, did anything notable happen that day?
Yes.
What happened?
The father, Scott Schara, was evicted from the hospital.
And do you think that the way that eviction was done, do you think that was proper?
No.
Okay, could you please explain to the jury why not?
Sure. So when Scott Schara, the father, permitted his daughter to come into the hospital, a waiver of a hospital protocol on visitation was made to allow him to accompany his daughter into the hospital. At that time, if there were any conditions by which his presence would be revoked, he should have been informed of those conditions. Failure to inform of those conditions would be improper informed consent relative to admission of the hospital. The other issue that was, what term did you use? Improper?
Yeah, I just want to know your
Okay,
opinion
yeah.
on how this thing was done.
So some of you may be aware of how evictions occur when people who are renting don't pay rent. And in those circumstances, the evictions require a written notice to give the person time to make arrangements and get legal assistance if necessary, and also give them time to answer any questions that have come up. And Mr. Schara was given no written notice. A nurse walked in with a guard, and he was told to leave.
Scott Schara testified that nursing instructed him on shutting off alarms. We've heard a lot of testimony about that, and that I think Dr. Shokar testified that that would never be appropriate. Do you agree with that statement?
No.
Okay, could you please explain to the jury why that is?
There are lots of alarms in the ICU. The ICU is a scary place. It is generally accepted amongst physicians in the ICU that a great many of the alarms, as many as 90% of the alarms, are clinically irrelevant. It is also generally accepted amongst physicians who practice in ICUs that these alarms interfere with proper sleep. It is also generally recognized amongst physicians in the ICU that lack of proper sleep is not good for patient recovery. Sleep is very important. If you deprive not just people, but any mammal, if you deprive any mammal, even a rat, of sleep, it will die. So all mammals need sleep, and humans are mammals. We need sleep. If we don't get it, our health will be adversely affected. And if we don't get it long enough, we'll die. So when alarms are interfering with sleep, sometimes it is in the best interest of the patient to make compromises about the alarms, determine which ones are not so important, and turn them off.
Dr. Burdine, Dr. Shokar testified while he was on the stand that Scott was Grace's best advocate. Why was it important that Grace have Scott by the bedside?
So getting patients to properly use respiratory equipment is difficult. The patient is asked to put something on their face, a mask, or some other device on their face. People do not like things on their face. If you have a cognitively impaired patient, it's worse. They're scared. And it is essential to have a family member assist with the acclimatization of the patient to this respiratory device. Now, I've been in the practice of sleep medicine, for 40 some years. And I have sleep apnea, and I use a CPAP machine and wear a CPAP mask. And even with all that I know about sleep and masks, it took me 6 weeks before I could wear that thing for 3 hours each night. That's how long it took me to adjust to having this thing on my face. It is extremely common to hear stories from patients who use CPAP or other devices on their face that they find it lying next to them in the bed. They wake up in the middle of the night and find the mask on the bed next to them. It's extremely common. Obviously, the mask doesn't do the patient any good if it's lying on the bed and not on the face. So it is essential for proper use of this equipment to have family members assist to comfort the patient, to get them to accept the use of the mask, to be watching for when the mask comes off and assist the patient for getting it back on in a comfortable way, and just to encourage the patient to do the best they can.
What was the result of Scott being evicted from the hospital?
Well, statistically, Grace's oxygen levels dropped 3 times as fast after he was evicted than prior to his eviction.
Okay. We're going to move on to the third overdose, day of death.
Going to the 13th now?
Yeah.
Okay.
Dr. Burdine, thank you. What 3 drugs were used to overdose Grace on October the 13th, day of the death?
The first one was Precedex, the second one was Lorazepam, and the third one was morphine.
And those were those drugs that we talked about yesterday, right?
Yes.
And we established yesterday that these drugs have a synergistic effect. Okay, and that means they sort of build on each other.
Right. The total effect is greater than the sum of the parts.
Okay. Morphine. Yeah. There's 2 more that look like this. These are from it. This is from yesterday. Thanks. Dr. Burdine, I'm handing you 40 and 41.
So 40 is a medication. It's a statement of what's happening with the medication. And the medication is norepinephrine.
Do you guys have the Lorazepam record? Need the Lorazepam record. The Lorazepam?
41 is Lorazepam.
So then I need the morphine. Need the morphine record. Got it? Okay, just for the record, Dr. Burdine, would you please publish what you have now?
I have Exhibit 41, which is a medication administration summary for Lorazepam.
New, right?
And I have Exhibit 31, which is a medication administration summary for morphine.
Okay, and then you press next. And then I'm going to give you one more that we talked about yesterday, Dr. Burdine. Instead of 25, I think yesterday. Administration summary for Precedex. Is that one right for you?
Yes.
And you mentioned yesterday, I think, that you're familiar with these sort of medication summaries as part of your practice.
Yes.
So doctor, I'm going to put a chart up on the screen here. It's a little small, but we're going to zoom in as we go to the different components. So this is a chart of the medications that were administered on October 13th. The green bars down here is the level of Precedex, and then there'll be an orange bar, and then there'll be two more orange bars and a gray bar. Those orange bars represent Lorazepam, and the gray bar represents morphine. So we're just going to be zooming around in this chart and talking about the different things that are happening. So first thing on this chart that I want to talk about on the 13th is the Precedex. Here on this first entry, you can see it's at 0.8, and it's at midnight here on the 13th. Based on the Precedex administration summary that you have in your hands, what was happening there at midnight on the 13th?
The Precedex rate, infusion rate, was increased from 0.7 to 0.8.
Okay. What was the effect of that increase on Grace?
So previously, Grace had adverse reactions with Precedex infusion greater than 0.7. The consequence of this is the first of a series of increases in Precedex on the 13th, and the consequence, or at least the first consequence of these increases, starting with the increase from 0.7 to 0.8, was metabolic acidosis.
Got it. Doctor, I want to look at 6:02 a.m. next. What's happening there?
At 6:02, the infusion rate is increased from 0.8 to 0.9.
Okay, was that a problem?
Yes,
Why was that a problem?
because this is higher than the rate at which Grace had two life-threatening events. So the event on the 7th occurred when the infusion was started at 1.0, and 20 minutes later, she had a life-threatening event. And on the 8th, it took a little longer, but she had an adverse event that required 8 hours of resuscitation with 2 pressors.
Okay, and this was, you said this was Nurse Haynes that was doing this at this time?
Yes,
Okay, was that the same nurse who was in charge of Grace's Precedex on October the 7th?
yes.
Okay, doctor, next one, 7 a.m. What's happening there?
The Precedex infusion rate is increased from 0.9 to 1.0.
Who did that?
That one is Nurse McInnes.
What was the effect of that increase? Was that right?
Well, this was an increase to the dose that nearly killed Grace on the 7th. This dose had not been reached on the 8th when she had the second life-threatening event. So at this time, they have increased the rate of the Precedex higher than what nearly killed her on the 8th.
Who was the treating physician while all this was going on?
On the 13th,
Yeah.
it would have been Dr. Schara.
Let's talk about 7:30 next. What's going on at 7:30?
At 7:30, the Precedex is increased from a rate of 1.0 to 1.1. This is a higher rate of Precedex than Grace has received at any time during this hospitalization.
This was the highest rate yet?
Well, it's the highest rate up to now.
Up to
It's going to get higher.
Up to this point. What was the effect of this increase?
What do you mean the effect?
I mean, was this okay? Was this proper?
Okay.
Yeah. What happened?
Well, eventually she's going to develop metabolic acidosis and she's going to develop hypotension.
Got it. And okay, let's just hit these last two here. 7:54 a.m. What's going on there?
At 7:54, the Precedex infusion rate is increased from 1.1 to 1.2. So this is a new high.
What about at 10:48?
At 10:48, the Precedex is increased to 1.4. Now, I don't think it went to 1.4 in one step, and so we're missing documentation on how it got from 1.2 to 1.4.
And you say that based on your experience with these kind of medical records?
Right.
Based on your review of the record, what was the maximum allowable dose that Nurse McGinnis could have turned this Precedex up to? Okay, so right now it's at max.
It's at the maximum dose, yes.
Okay. And the Schara family testified that, or Scott and Cindy Schara testified that no one told them about these increases in Precedex and that they never consented to Precedex. Was that a breach of the medical standard of care, doctor?
Yes.
This is an opinion that's outside the scope of the motion in limine.
I rephrase, Your Honor. Who was the treating physician at this time?
Dr. Shokar.
Okay. The Schara family testified that Dr. Shokar never told them about these increases and that they never consented to Precedex. Was that a breach of the standard of care for Dr. Shokar?
Yes.
Okay, and why is that?
Two reasons. One, no permission from the patient advocate had been given for the administration of Precedex. And two, we now have two previous life-threatening events. So any discussion of risk and benefit, the risk is no longer a 1 in 4 to 1 in 3 chance of hypotension. The risk is probably 99% or higher that you will have life-threatening hypotension. Obviously, a risk of 99% or higher of a life-threatening event needs to be discussed with the patient advocate before you give it.
Dr. Burdine, I'm handing you that's exhibit 42. Part of this exhibit that I'm interested continues on to the next page. Take a second.
Okay.
Okay, do you see what's going on there on the top of the second page?
Yes.
What is that?
So this is an order changing what's called the code status of Grace Schara.
When you say code status, what do you mean by that?
Code status is the level of care that the providers are permitted to administer in the situation of life-threatening events.
What are some of the options of code status?
One option is intubation or do not intubate. One option is cardiopulmonary or chest compressions or no CPR. One option is no treatment at all versus the permission of medications. Those are the roughly the three categories.
Dr. Bernard, I forgot to ask you, are you familiar with these types of orders as part of your practice?
Yes,
Okay. You deal with these on a pretty regular basis.
yes.
Can you tell from this record when this, or I'm sorry, what does this record reflect? I mean, what's happening in this record?
So Grace's status was changed to no code.
Okay, and just to be clear, what does no code mean?
Do not do anything.
When you say do not do anything, can someone still receive medications while they're on a no code?
Yeah, so if there's a sudden change in her condition, if she has a sudden drop in blood pressure, a sudden change in her EKG, this would mean you do not do any interventions.
Okay, so the way this order was entered, that means you do not do any treatment if there's a crash.
Correct.
Dr. Nurse McGinnis testified yesterday about a purple wristband that's in use at St. Elizabeth Hospital, and that purple wristband.
Objection, Your Honor. This again is an opinion beyond that which this witness has given.
We've never heard this.
Yeah, so a couple of things. I don't know what the question is yet. He's in the middle of it.
Sorry.
The end of the question.
Okay.
He was talking about Nurse McGinnis's testimony yesterday, which I ruled was proper to tell witnesses about. And then if he were to, which I don't think is an opinion question yet. So the objection's overruled for now. Go ahead.
Okay, I'm just going to start from the top there on that one. Nurse McGinnis testified yesterday that there is a wristband system in effect at St. Elizabeth for people with DNR orders, and that it's a wristband that goes on the patient's wrist, and that it's a purple wristband. Are you familiar with these kind of wristband systems?
That's not what we use.
Okay. What do you use?
Ruled. Go ahead.
We use status of code, no code, intubate, do not intubate, CPR, no CPR. And it's recorded in the chart, and it is made sure that everybody caring for the patient knows what the status is.
Doctor, can you tell what time this order was entered?
This is 10:13 at 10:56 a.m.
And just a minute ago, we talked about Precedex being turned up to the max rate. What time did that happen? Should have it.
Precedex was turned up to the maximum rate at 10:48 a.m.
Okay. So 8 minutes after Precedex hits the max, there's a DNR order entered onto the chart.
Yes.
Doctor, what does the standard of care require of a physician in regard to entering one of these orders in terms of communicating with the patient or the decision maker?
So there needs to be a conversation between the physician and the patient or advocate. And you have to determine that if it's the patient, you have to determine that the patient is competent and aware of the enormity of the decision they're making. And you have to determine that the decision is being made without coercion. In my experience, these discussions are always witnessed so that there are no questions about what happened. And you have the patient or advocate will sign the order. The physician obtaining the consent will sign the order, and the witness will sign that they witnessed the order.
Dr. Scott and Cindy Schara testified that they never consented to a DNR order, and yet one was entered. Is entering a DNR order without consent a breach of the medical standard of care?
Yes.
Why is that a breach of the medical standard of care?
Well, that's the worst kind of breach of the standard of care, because you're supposed to be delivering medical care, and now you're entering an order to not deliver medical care.
So once a DNR order is on the chart, whether it gets there properly or not, can it be removed at any time?
Yes,
How is it removed?
the patient or advocate says, I changed my mind. I do not want to be DNR. And then they can say, so if they're do not intubate, they can say, I want to be intubated. If they're no code, they can say, I want everything done. Or they can say, I want everything done other than CPR. They have the full range of choices.
And can a power of attorney make those sort of decisions?
Yes, if the patient is not competent to make the decision, power of attorney is the one who makes it.
Got it. And how fast is that change effective?
As soon as it escapes the person's mouth,
Immediately.
immediately.
Okay. They don't have to wait for an update in the medical record or anything like that?
No,
Okay.
I would like to clarify something, because sometimes there is confusion when these things happen. And you always err on the side of saving the patient when there's confusion, and you let things get sorted out later. So if you receive information that the DNR has been revoked, you do everything until you hear from the patient or advocate otherwise. If you're getting conflicting information, you do everything until it's sorted out.
Dr. Grace's parents testified that they were on FaceTime with Jessica right before Grace died, and that they were screaming to save their daughter and that she's not DNR. Based on your experience and in your opinion, is that sufficient to revoke a DNR?
Yes,
Again, that's a violation of the motion in limine. It's a brand new opinion.
Counsel, you want to approach?
Yeah.
momentarily. Get you back in here within a few minutes, hopefully. All right, everyone may be seated. This is a hearing outside the presence of the jury. Attorney Frankowiak, you said during the sidebar that you think it's a violation because it's a new opinion, and I listened to you argue that for a bit. I don't think you said anything, Attorney Fleiter, but I said I'm going to allow it. And then you said it's gonna totally affect the case, I think is what you said, or blow up the case or something. And I said, well, I didn't understand how that's gonna happen based on this opinion, but that's when I said, well, let's just excuse the jurors. So go ahead.
Honor, the case was based upon the opinions that were given by these witnesses. We have a nursing expert named against the hospital, and Verdine was named for physician opinions. He had a couple of opinions related to the removal of Mr. Schara from the hospital. I attempted to clarify that with him at his deposition for the purpose of avoiding this exact situation where we didn't have a good box in which to place this testimony. He told me specifically, and it will come up when I cross-examine him, but this is something completely different. This changes potentially, this is a new opinion that at this point, I'm not sure can be rectified. He told me that his only opinion against any nurse was Allison Barcolds, and his only opinion against Allison Barcolds was for the removal of Mr. Schara. He said he had no other opinions relative to any other nurses. This witness is about to give an opinion that he feels the nurses who were present at the time of the arrest failed to meet the standard of care by attempting to resuscitate Grace without intubation. Allison Barcolds was not there. These are other nurses that are unnamed, that have not been identified, and this is a brand new opinion against those nurses, which they intend to try to attribute to the hospital. That is absolutely a brand new opinion that we were not able to counter with any other witnesses because it was never in the case until now. And that was the purpose of that motion in limine, which was granted. I thought we had really nailed that down, Your Honor, and this is a very big concern. If he's allowed to give a brand new opinion that implicates nurses other than the single nurse and the single issue that he told me he had an opinion on. Remember, he's a physician expert, and I'm relying on the fact that he had limited opinions relative to the nurses, and this is a brand new one.
Okay. I'm going to go to Attorney Guzzi next, and then I'll allow plaintiff kind of respond to all of them.
No, I think Attorney Frankowiak expressed all my concerns and my position.
Attorney Fleiter.
Yes, Your Honor. We were sort of in real time there. Can I get a read back of the question? I don't remember what the question was exactly.
I guess, Your Honor, the only question I'm sorry. The only
Second, let's just read back the question first. So the court reporter is going to now go back and do that.
Your Honor, I don't think that's.
I am confused by the objection even more than what it was during the sidebar, but so Attorney Guzzi, I'm going to let you go, and then I'm going to turn it over to you, Attorney Fleiter.
Yeah, I guess I was appropriate for the witness to be present during this conversation.
I think it is. Okay, so comments that you said that I don't think you need to respond to, Attorney Fleiter. So first of all, cross-examination, you're going to cross-examine on everything you want. as long as it's anything he testifies to. So I'm comfortable with, I think that was your first point. The second point that I want to make before I turn it over to you, Attorney Fleiter, is when you say that this 9-minute window has never been in the case, I completely disagree. So I'm familiar with everything I've read in this case and the motions that were filed, that this telephone call, FaceTime call that happened between 7:18 and 7:27 was going to come in at trial. And in fact, it already has come in at trial, and it will continue to come in at trial. And so that's not new, and it's not something that we should be, saying what's never been in the case. Let me finish.
Right.
I would think that all of us are going to understand that Dr. Shokar and Nurse McGinnis and whoever else you call are going to offer opinions about if somebody said we change our mind, we don't have a DNR, which is what I understand was going to happen in the case many months ago. That shouldn't be a surprise to anybody. So the question that was asked is, is it okay to revoke during a FaceTime call? I don't know what his answer is going to be, but let's pretend he says yes. And now that's why I want to turn it over to you, Attorney Fleiter. What else are you going to get into?
Your Honor, on that subject, that's the question. I'm trying to establish that the family can revoke the DNR by the standard of his experience. Is the DNR sufficiently revoked when the family's screaming she's not DNR, save her? I'm not commenting. We're not going to comment on whether the nurses breached the standard of care by not responding. We have another expert who's going to talk about that. So at risk of thinking that maybe that's all I'll say.
Okay. So the objection's overruled. I'm going to allow you leeway to ask those questions. You can clear it up in cross-examination. I think it's an issue that eventually the jury's going to have to answer. So today, at the end of the day, as they were walking in before, I told you I'd like to get a handle on where the case is at. So I've been trying to start what I perceive to be the verdict form. And one of those questions will be around the incident on October 13th. So for example, I think we would ask the jury, a question similar to, did the family revoke the DNR if it wasn't in place? And so for this expert to answer that question, and your experts to answer that question, I will be helpful to the jury in coming to whatever conclusion they want to come to. So the objection's overruled. Let's bring the jury back.
There was no. Good question.
All right, everyone, maybe seated. So I don't know if any of you are basketball fans, but the NBA championship was on last night, and with like 24 seconds or so, there was a out of bounds play or foul, and the refs had to go to the replay booth, and it took like 5 or 6 minutes for what seemed to be obvious that when you're watching on TV, it was not a foul. So we get frustrated when you're there and just say, let's keep moving, right? Because some of us go to bed early. And that's what happened here is when I listened to the attorneys, it was important enough that I didn't want to make a quick decision. So, and I don't want you to read into anything other than that it was important enough that I wanted to get you out, be able to hear arguments and understand exactly what was being said in a non-rushed way. And then my decision on it was the objection is overruled. I'm going to allow the question to be asked. And I'm going to have the court reporter just go back and read that question loud. She wasn't here yesterday when the court reporter didn't read it loud enough. So as loud as you can, she's just going to read the question and we're going to have the witness answer it.
Grace's parents testified that they were on FaceTime with Jessica right before Grace died, and that they were screaming to save their daughter, and that she's not DNR. Based on your experience and in your opinion, is that sufficient to revoke a DNR?
That loud enough? Okay, go ahead, doctor.
Yes,
Okay, so doctor, just to be clear, in your opinion, when the family was screaming for help, the DNR would have been revoked at that time?
yes.
Okay. Doctor, we've heard some discussion about whether treatment was futile, at some points in Grace's case. First of all, can you just, I guess, first explain what that means if treatment is futile?
Well, you can have situations that go so far that a physician, no matter what they do, cannot reverse things.
At the time the DNR was revoked there on the 13th, was treatment futile at that point?
No,
Okay, Grace could have been saved.
yes,
Okay, and even given the overdose that you've talked about in this case on the 13th, what was Grace's chance of survival if treatment would have been given based on your experience of drug overdose?
well, at this time, because you're dealing in part with a narcotic or opioid or overdose, reversal with naloxone, brand name Narcan, it can appear magical. I have seen people brought in who had no heartbeat for 20 minutes and were getting manual CPR.
Relevance.
Overruled. Go ahead.
And we're getting manual CPR en route to the hospital. And after an amp of Narcan, in 10 seconds, they sat up out of the bed, went from lying flat, completely unconscious and unresponsive, to sitting up, talking.
Doctor, you just talked about Narcan, the morphine reversal drug. what other treatments should have been given at this time?
There is a reversal drug for benzodiazepines. Its slang name is Reversed because Versed is a benzodiazepine, so Reversed. I can't pronounce the generic name, but that was available. Unfortunately, there's no reversal agent for Precedex, but Precedex could have been stopped, and that would have been the first step. And since Grace was suffering from metabolic acidosis, the administration of bicarbonate could have been done. And since Grace was hypotensive, the same measures that were taken on the 8th with norepinephrine and dopamine could have been done.
Doctor, I want to go back to the timeline that we were looking at earlier. We talked about this green area here, which is the Precedex, and you can see it going up. The next thing I want to talk about is these orange bars here, and those represent doses of Ativan or Lorazepam. Can the jury see those bars okay? Okay. Doctor, I know you have the medication summary in front of you for Lorazepam, right?
Yes, Exhibit 41.
Yep. The first dose, according to that summary, correct me if I'm wrong, talking about the 13th, first dose on the 13th was at 11:25 a.m. Is that right?
Correct.
And at this point, we've already covered that Precedex was at the max rate. Is that right?
Correct.
And was this 11:25 a.m. dose of Lorazepam, was that beneficial to Grace's condition?
No.
What was the effect on Grace's condition as a result of this Lorazepam?
Her respiratory status deteriorated significantly.
Would it have been better if Grace did not receive this Lorazepam at all on the 13th?
So this is a complicated question.
Okay.
The Lorazepam at this time was given to facilitate placement of a feeding tube. The best decision of all would have been to put the feeding tube on hold so the Lorazepam would not have been necessary.
We've heard some testimony, Doctor, that Grace's condition was critical from Dr. Shokari. We've heard some testimony that Grace's condition was critical on the 13th. What would be the purpose of a feeding tube with a critically ill patient? What would be the point of that?
Well, the purpose of a feeding tube is to provide nutrition if the patient cannot eat. It's not so much whether this condition is critical, but if you're going to make somebody DNR, there's really no point in placing a feeding tube.
Right. So if you think someone is about to die, are you saying there's not really a point to the feeding tube?
Correct.
Okay. All right, I want to talk about the next one up here, 546. Are you with me?
Yes.
We talked earlier in the trial or earlier in your testimony about something called a RAS score. Do you remember that?
Yes.
Okay, just briefly, could you just remind us what a RAS score is?
It's a sedation level score. The highest number is +3. That's very agitated. And I believe the lowest number is -3.
Okay, and not specifically to do with RAS score, but do you remember from your review of the record, sort of what Grace's level of sedation was here on 10/13 at this first dose, 5:46 p.m.?
At 5:46 p.m., Grace was either somnolent or unresponsive.
Okay. Doctor, what's the purpose of giving Lorazepam to a somnolent patient?
I cannot think of any.
Okay, because they're already,
You can't really get more sedated than somnolent.
yeah, I mean, a somnolent person, I mean, what's their agitation level?
Correct.
There is no agitation, is that what you're saying?
Correct.
Was this 5:46 p.m. dose of Lorazepam, was it beneficial for Grace?
No,
Why not?
it suppressed respiration at a time when she was trying to maintain her pH in the face of progressive metabolic acidosis due to the Precedex.
Let's talk about the next one. Last one of the day, 5:49 p.m. What was Grace's sedation level at this time?
Either somnolent or unresponsive.
Okay, so Grace is somnolent and she gets another dose of Lorazepam. That's what that record says?
Yes,
Does that record say anything about the purpose of that dose?
no. Oh, I'm sorry, the 1749 one does say something.
Okay, that's what I thought. What does it say?
Respiratory rate 55 given for work of breathing.
Got it. And just so we're clear, in your opinion, why was the respiratory rate 55 at this time?
Compensation for metabolic acidosis.
And we're going to get to why you think there was metabolic acidosis here in a minute. And you just said work of breathing. Based on your review of the record here in this case, what is meant there by work of breathing? What are they trying to do?
Well, to take breaths in, you have to contract muscles, you have to generate pressure, and generating pressure and pulling in volume at that pressure is work. That's the thermodynamic definition of work. And so work is required to breathe. But in this case, the work of breathing was not a problem. It was the only thing keeping Grace alive.
And was the work of breathing trying to be decreased by slowing the rate? Is that what we're supposed to understand from that?
Well, the work of breathing could be decreased by slowing the rate or slowing the tidal volume, and both would have been bad.
Okay. And by tidal volume, what do you
The
mean by that?
volume, the depth of your breath,
Okay, how much air is going in and out?
how much air you suck in with each breath.
Dr. Shokar testified that he gave the order orally for this 5:49 p.m. dose of Lorazepam. Was that order a breach of the standard of care?
Yes,
Why is that?
because Grace needed all the ventilation she could muster. It was the only thing keeping her alive.
All right, doctor, we're going to look at the lab results that we talked about yesterday. We talked about some blood gas readings on October the 8th. We're going to be looking at October the 13th now. previously marked as exhibit
39.
39. Up on the screen there for the jury is a snippet of this exhibit. That's what we're going to be talking about. Dr. Bernard, could you look up at the screen real quick and just see what we're looking at? This is the October 13th.
Right, this is a lab value.
Okay. Now, the two numbers here that are highlighted, the 19 and the 23, these are next to a reading called TCO2. Are you with me?
Yes,
Okay. And just as a reminder, we had a slide earlier that talked about bicarbonate and TCO2. And this is the slide here up on the screen, but I just want to be clear about just basic. What is bicarbonate one more time?
bicarbonate is base. It's what's when carbonic acid dissociates, it dissociates into a hydrogen ion, which is acid, and bicarbonate ion, which is base.
And earlier in the day today, we talked about how less than 20 bicarbonate would be critical high acid. You remember that?
Correct?
And one last thing on this slide, bicarbonate can also be measured with this TCO2 number. Is that right?
Correct.
Okay. So I want to go back to the labs here. Tell the jury what we're looking at with these two numbers. What's happening?
So at 357, the bicarbonate or the total CO2 level is 23, which is normal. And 10 hours later at 1350, or 10 hours later at 1350, the total CO2 is decreased to 19.
And
The only plausible explanation for that is a significant metabolic acidosis.
so just to be clear about your opinion is that at 1:50 on October 13th, 2021, the day that Grace died, Grace was in metabolic acidosis.
By 1350, yes.
We discussed earlier today that Dr. Shokar was the treating physician on the 13th. Does that include at this time based on your review of the records?
Yes.
Based on your review of the records, what did Dr. Shokar do in response to these readings?
Nothing.
What should have Dr. Shokar done in response to these readings?
A blood gas, an arterial blood gas should have been done to confirm that you were dealing with metabolic acidosis and to determine whether or not respiratory compensation for the metabolic acidosis was adequate. In addition, since the most plausible explanation of this blood value is lactic acidosis, a lactate level should have been ordered.
Doctor, just so everybody's clear, I know your opinion is that Grace was in metabolic acidosis at this time. What physiological or what body condition was causing this metabolic acidosis?
The Precedex.
What vital sign, I guess, was affected by the Precedex?
So you have blood pressure and you also have distribution of blood flow. but basically there are cells in Grace's body that are not receiving enough oxygen due to problems with blood flow.
And you also said possibly distribution of blood, I guess blood flow, which would include blood pressure.
It includes blood pressure, but also the distribution of blood flow.
We're gonna just jump ahead a little bit. I know you mentioned that Dr. Shokar should have ordered an arterial blood gas test here at this time and a lactate test. Did Dr. Shokar order an arterial blood gas test at any time on the 13th?
Yes,
Okay, what time about?
it was much later. It was after 1800,
After 6 p.m.?
6 p.m.
And was that blood gas performed?
No,
Okay, do you have an understanding from the record of why not?
yes.
Please explain.
The technician came to obtain the blood specimen, and I demonstrated to the jury yesterday what maneuvers they would do to locate the artery from which to gain the specimen. Grace had no palpable pulse at the time, so they couldn't find an artery to obtain the blood from.
We're gonna go to a new chart, doctor. It's got the stuff from the old chart, but it's also got something new here at the bottom. This is Grace's respiratory rate on the 13th. Can't zoom in too much. I can get us a little closer. Okay, doctor, as you look at this chart, do you see any correlation between the administration of these drugs and Grace's respiratory rate?
Yes,
Okay, would you explain that?
Your Honor, may I point to the screen? So here, the respiratory rate is fairly even. Here we see the Precedex being ramped up to the maximum value. We see an increase in the respiratory rate, which is compensation for the metabolic acidosis. And then we have points where there's depression, and part of that is this drug here. Part of it can be other things. Then respiratory rate climbs again, keeps climbing, and it gets to this point. And at this point here, she is probably at maximal voluntary ventilation. She cannot increase her ventilation anymore. She cannot lower her PCO2 anymore. She cannot provide further compensation for metabolic acidosis.
Thank you, doctor. Okay, I want to talk about this last bar here on the chart. It's gray. It's morphine. Could you remind the jury what morphine is?
It's a narcotic or opioid.
Does it have any effect on a person's respiratory rate?
Yes, it lowers it.
Based on your review of the record, sorry, Linda. Based on your review of the record, was morphine ordered for Grace on October 13, 2021?
Yes,
Who ordered it? Who ordered the morphine?
Dr. Shokar.
And based on your review of the record, can you see who administered the morphine?
Nurse McInnes.
Okay, and how is morphine administered in this situation?
It's injected into an IV.
Okay. And then that drug then goes down through the IV and into the vein?
correct,
Okay, and then into the person's body,
correct.
and then it spreads throughout the body. Is that right?
It's distributed, yes.
Distributed. This next slide here, Doctor, it's going to have snippets from two of the documents you're going to be looking at, the Precedex summary and the morphine summary. Disregard the exhibit numbers on here. They've changed. But let me know when you've got those two documents in front of you.
Oh, Precedex and
Morphine.
morphine.
Yep, that's right.
Okay, I have one in each hand.
Okay. I want to talk about the Precedex one first, and we're going to be on the last page. This is October 13th, 6:37 p.m.
Yes,
Explain to the jury what's happening in this Precedex entry here.
so at 18:37 or 6:37 PM, the Precedex is discontinued.
And what is this bottom, or sorry, let's go to the morphine record.
Okay,
There's an entry here for 10:13, 8:15, or sorry, 6:15 p.m. What's happening here in this record?
at 6:15 PM, the morphine is administered.
Okay, and I see this little 18:30 notation right below the 18:15. So this 6:30 p.m. right below this 6:15 p.m. Do you see that?
Yes,
Why is there two numbers there?
oh, I'm not sure.
Okay, you're not sure. Dr. Shokar testified that the Precedex was shut off before he ordered the morphine. Does the record reflect that?
No,
What does the record reflect in terms of the order of the shut off and the morphine?
the record reflects that the Precedex was turned off after the morphine was administered.
Dr. Shokar challenged this record and said that it was not accurate because he was sure that he turned off the Precedex before giving the morphine. Is there anything in your experience that would prevent a medical provider from putting the accurate time in the medical record, even if they did it after the drug was given?
Objection calls for speculation.
No, the record can be corrected. If the record is a proper one, there will be timestamps as to when the record is corrected so people can follow how things were done. But you can correct the record after the fact.
In fact, you can correct the record a month after the fact if you want.
Yes,
And you didn't see any of those sort of corrections in this record, did you?
no.
I want to talk about this last drug, morphine, doctor, on October 13th, day of death. Dr. Bernine, based on your review of the records, what was the condition of Grace's respirations at the time the morphine was given?
Grace had already reached maximal voluntary ventilation, and it was inadequate to deal with or compensate for the metabolic acidosis. So at the time the morphine is being given, her pH is dropping. And I have a fair amount of experience with these kinds of situations. And my expert opinion on the pH. Grace's pH at the time the morphine was given was probably 7.0 or less.
And just so the jury understands what that means, a pH of 7.0 or less, what does that mean?
You're in danger of dying.
And this was prior to the morphine.
This is prior to the morphine.
And you mentioned just a second ago, at this time, Grace's respirations were at maximum ventilation.
Right, and we also have respiratory therapy records that indicate that her tidal volume was near the highest it had been for the entire hospitalization, and her rate was in the well, at least mid-50s.
So is it fair to say, in your opinion, that Grace's rapid breathing condition was the only thing keeping her alive at the time the morphine was given?
Yes.
Dr. Shokar testified that it was his intention with the morphine to slow Grace's breathing. My question to you is, would slowing her breathing impair her ability to hyperventilate to fight this metabolic acidosis?
Yes.
And what happened as a result of Grace's breathing being slowed?
Drop further, in my expert opinion. Her pH went from around 7.0 to 6.8, probably in a matter of a minute.
Your Honor, I just have a few more questions on this section. If we could just extend the break time by maybe 5 minutes. Okay. And doctor, finally, what happened as a result of that drop in pH?
The drop in pH, it took a while, but the drop in pH eventually resulted in her death. She had asystole, her heart stopped, and she died.
Dr. Burdine, was Dr. Shokar's order for morphine at this time a breach of the medical standard of care?
Yes,
Why is that?
because in the face of metabolic acidosis and somebody whose body is screaming at you that they are desperately compensating for metabolic acidosis, the worst possible thing you could do would be to slow their rate of breathing.
I think I know the answer, but I just want to be clear. Would Grace have been better off if Dr. Shokar never ordered the morphine?
Yes,
Good time for a break, Your Honor.
Members of the jury, we're going to take our morning break. It'll probably be about, I think, 20 minutes work for all of you. Just to let you know, last night after you went home, the attorneys agreed that this is going to be the only witness today. It's going to still take a long time, so it's not like we're going to be done anytime soon. But as soon as we get done with this witness, which will probably be sometime this afternoon, we're going to be done for the week, and then we'll pick up Monday morning. But I just thought I'd let you know that. I know lunch is being ordered, and I think all of you have done that. But if you haven't, do that during the break so they can do it once you come back into court. The jurors are excused. All right, everyone may be seated. This is a hearing outside the presence of the jury. Dr. Burdine, if you want to step down, you can. And if you could maybe just be back here in 20 minutes. Okay, thank you. During that session, the new exhibits, I believe that were presented and discussed were exhibits 41 and 42. Any objection to receiving those? Okay, so those are received. What's the status or how much longer do you have? And again, not that I'm trying to rush anybody.
Best guess, an hour plus or minus 30 minutes.
Okay.
Yeah.
And then a feeling on who's going first on cross-examination? Okay, and window of time is,
It could be an hour or two, depending on how many times I have to go to the deposition transcript.
okay. So we're going to go in the afternoon, do you think?
I think there's a very good chance.
Okay.
Yes.
Then we'll order lunch.
I think mine will probably be 20, 30 minutes.
So it seems like, okay, so we'll order lunch for them, and then the plan will be that we'll have lunch and definitely have some part in the afternoon. Anything else that we need to do now before we take a break?
No, Your Honor.
Anything from defense?
Your Honor.
Why don't we say 20 minutes from now, so like 5 to 10 on that clock? We're adjourned. The face or in person?
you serious?
So we're on the record in 23 CV 345. I know the jurors are coming back down the hallway. So Dr. Burdine, you're back up on the witness stand. Go tell her. All right, everyone may be seated. Welcome back, and I think we all know, but that none of us were the ones that were having the toast. But there was some burnt toast in a toaster, and it definitely came from back there because we could smell it in the hallway, and I'm sure you all smell. I'm not going to call out who it was, but. So sorry about that, and there's a little bit of entertainment, but hopefully we're ready to get going. Where we're at is in the direct examination of Dr. Burdine still. When he finishes, which will be before we take our next break, then they'll start the cross-examination, and we're going to break for lunch around 11:30, which is when it's going to be delivered here. So we'll pause wherever that is. Your witness attorney, Flighter.
Thank you, Your Honor. Dr. Burdine, before the break and fire alarm, we had just finished talking about the morphine and that it was intended to slow the breathing, and that breathing led to a worsening, and the slowing of the breathing led to a worsening in the metabolic acidosis. Does that sound right?
Yes.
Okay. When we get the screen up, no. Dr. Mini was then marked exhibit 43. Could you please describe to the jury what that document is?
This is a respiratory therapy flow sheet.
Okay, and that's what we're looking up. That's what we're looking at up here on the screen, right?
Yes.
Okay. Now, the first thing I want to point out is there's a date section up here at the top. Do you see that? Yes. Okay, and it says 10, but then it looks like there's a hole punch scan that killed that day number there. Do you see that?
Yes.
Okay. What day do you believe that this record is from? And we'll talk about why you believe that after this.
The 13th.
Okay, and why do you believe that this was from the 13th, doctor?
Because subsequent pages are all the other days, starting from 12, decreasing to the 7th, I think is the first day we have.
Got it. So we have all the other days.
Yes.
Got it. Now, here across this second row here, we see time there. Do you see that?
Oh, okay. I've got.
Well, you can look at your copy as well. I'm just
Well,
moving
I
it around
have
here.
to see what you're talking about.
Time up here by right underneath equipment. Yeah.
Yeah.
So then the times that we're talking about go right across that row, is that right?
Yes,
Okay. Now, what times here on the 13th do you want to talk about with the jury? Which ones do you think are important?
well, I think we should talk about 1600 and 1841.
Okay, 1600, 1841, that would be the second to last in the last column here, is that right?
Yes,
Okay, and along the left side here, there's a lot of different metrics or stats. Which ones do we need to be looking at?
so we want to look at the row that's labeled SPONT space capital V capital T. That's spontaneous tidal volume.
I want to highlight that for the jury, and I'm sorry, I was looking for my pen. Would you say which one we're looking at one more time?
SPONT space capital V capital T. That stands for spontaneous tidal volume.
Okay, I just crossed it out on accident.
Here.
Sorry, Your Honor. Okay, thank you. Want to highlight. Here, right here. I got it. Okay, thanks for the patience. Okay, so we're looking at spontaneous volume here. What does that mean?
That is how deep the breaths are.
Okay, how deep they are. And then there's some numbers here that go, right down this column. And I know you said you wanted to talk about 1600 and 1841. So the numbers I see there are 696 and 676.
Looks to me like 698 and 676.
Well, it's hard to tell, but 698 or 696 here.
I probably have more experience reading the handwriting of RTs than you do.
I have no doubt about that. Okay, doctor, what do we want to say about these two numbers here now that we've kind of got an understanding?
So the first point is at 1600, the tidal volume is higher than the other numbers on this day. And if you look through all of the days, I believe this is the second highest tidal volume during the entire hospital stay. So a claim that you need to decrease the rate in order to increase that number seems to not make any sense.
And just as a reminder, what time was the morphine given?
Let's see. $18.15.
18:15. So that's 6:15. This last column here was taken at, looks like 6:41 p.m.
Correct.
Okay, so we have a data point here from before the morphine, that's 1600 or 4 p.m. And then we have a data point here from after the morphine. What changed in those numbers and what does that mean?
So the tidal volume decreased, which was the opposite of the stated intent.
Dr. Burdine, I'm handing you what's been marked as exhibit 44. A couple charts on that page. Could you describe what kind of charts those are, or what those are called?
These are rhythm strips.
Okay, and we have one of those rhythm strips up here on the screen for the jury. Could you describe what a rhythm strip is, what this is showing?
I'm gonna need, Your Honor, may I point?
You may.
So you are looking at two separate leads of EKG. This is one lead. This is another lead. These are what are called QRS complex These are ventricular contractions. Now, with the normal heartbeat, the normal EKG, you have a B wave that precedes QRS. The B wave is contraction of the atrium. So an electrical impulse starts in the SA node, causes the atrium to contract, which helps complete the filling of the ventricle. And then it goes through the AV node and fibers in the ventricle causes the ventricular contraction. Now in the normal EKG, the QRS complexes are narrow. There's a certain limit on how much time they take. These are wide. And the reason they're wide, so there's no B wave, wide QRS, and again, this is 2 leads at the same period of time. This is what's called the ventricular escape beat. So what has happened here is you have sinus arrest. There are no impulses coming from the sinus node. You have a single ventricular escape beat, and that's the last heartbeat for Schara. And then you have asystole.
Thank you, doctor. You just mentioned something called the sinus node. Could you explain to us what the sinus node is and what it does?
The sinus node is the beginning of the electrical impulse to cause heart contractions. And it's basically our main pacemaker.
Got it, perfect. Okay, I'm gonna put one more chart up there. There's a lot going on, so we're gonna zoom in on what we're gonna talk about here, so bear with me. I wanna zoom in over here. These kind of teal bubbles here, here, here. These are SpO2. Okay, so that's her oxygen saturation.
Right. And the P stands for pulse.
Got it. Now, what I want to talk about, and I think this is very, very important, is that we've already established the morphine was given at 6:15, right? So we're right around in here. The charting shows an increase in oxygen right after that morphine was given. Now, we've heard testimony that Grace's oxygen did in fact increase following the administration of morphine. Do you agree with these readings, Dr. Burdine?
No.
And why don't you agree with these readings?
So a pulse oximeter works. Can I approach the jury? The pulse oximeter can be placed on many parts of the body. The most common is on a fingertip. Believe it or not, every heartbeat, your finger swells. Now, if you sit on your hands at night, you can feel that. Your finger swells. What is added? So before the heartbeat, you've got bone, fingernail, soft tissue, venous blood. Then the heart beats, it swells the finger, but the swelling or increase is all arterial blood. So what the oximeter does is it detects the maximum value in the waveform and the minimum value in the waveform, and it uses those points in time to compute an average of the readings from two light sources and how much light is detected. So there's light shining through the top of your finger and being detected at the bottom. One is infrared, one is visible light, and it does go through your finger. So if no pulse, you have no waveform. You have no waveform, you have 0 divided by 0. It's a nonsense number. So the first thing that has to happen is the machine has to be able to detect the pulse. And if you've ever seen one of these oximeters, it has 2 readings. One's for the oxygen level and one's for the heart rate. And the way you tell whether it's working, the first method is the heart rate correct? If the heart rate's not correct, then the O2 signal is worthless. Now, it's possible for the heart rate to correct and the O2 signal is still worthless, but that's more complicated.
Thank you, doctor. I know that you said at the beginning of this case that you reviewed some deposition testimony. Is that right?
Yes,
Okay. And when you reviewed that testimony in preparation for your original reports and, for testifying here today, was there any testimony in those depositions that impacted your opinion on whether or not these O2 oxygen saturations were correct?
yes.
Would you please tell the jury what those pieces of testimony were and who made them?
So Jessica's deposition and also Nurse McInnes's deposition, and they both gave testimony of the events around 6 p.m. or 1800, and they both describe a problem where there are 3 oximeters in the room, and they are all 3 reading different numbers.
And they can't all be correct, right?
Correct. They cannot all be correct. In this case, they were all wrong. There wasn't a right one and a wrong one. They were all wrong.
Besides the scratch that. Besides the readings on the machine, did Jessica, Grace's sister, did she say anything else in her deposition that influenced your opinion here?
Well, both of them did. So Nurse McInnes notes about this time that Grace had lost her blood pressure. Those are her words, lost her blood pressure. So if you have no blood pressure, you can't have the swelling in the finger to generate the signal for the oximeter. And Jessica testifies that the waveform wasn't hilly like it was supposed to be.
What is a waveform?
The waveform is the waveform that's illustrated up is during systole and down is during diastole. The normal pattern, I'm going to draw it so it's correct for you. It'll be backwards for me. So you should have an up and a ramp down, up and a ramp down, an up and a ramp down. This is what we call a sawtooth pattern. That's what you should see. If you have a sawtooth pattern, the machine can detect the heart rate, and then you can see if the heart rate is correct. If you have a nice sawtooth pattern and the correct heart rate, then your oxygen saturation is going to be reliable.
Doctor, is this the thing in the hospital room that has the up and down on the screen?
Yes.
Okay.
Well, I mean, there are other things that have up and down, but some of them are EKG, and some people have special monitors to monitor arterial pressure and other things. But in most rooms, you've got a pulse oximeter, and if it's working correctly, it's a sawtooth.
And I guess what I'm getting at is it's not surprising to you that Jessica would have been able to see this screen.
No, it's obvious.
what's been marked exhibit 45. Would you please explain to the jury what that is?
Yes, this is a telemetry output from October 13th, and there's a number of telemetry signals coming from various channels.
I've highlighted two of these rows. I highlighted ECG-HR and I highlighted SpO2 rate, and both of those say beats per minute beside them there in the title. Would you explain what those readings show?
Right. The ECG hyphen HR is the heart rate determined from the electrocardiogram, the electrical signal. The SpO2 hyphen rate is the heart rate determined from the oximeter waveform.
And so both of these numbers are detecting heart rate just in different ways.
Yes.
Okay, and you can only have one actual heart rate, right?
Yes.
Okay, so when these two numbers don't match, I mean, you don't have two different heart rates. So when they don't match, what does that mean?
Well, it means the pulse oximeter is wrong.
And why would it be wrong?
The usual reason is low blood pressure, but it can also be wrong because the probe has come off. A number of things can cause it, but you have a bad signal.
But I just want to be clear, either way, if the numbers don't match, you're not going to have accurate readings. Is that
Correct.
Okay. Based on your review of the record, what, if anything, did Dr. Shokar do in response to these mismatched rates in the vital signs?
Don't think he did anything.
Doctor, we've talked about ventilators and a number of previous witnesses. Did Grace need a ventilator at any time while she was at St. Elizabeth Hospital?
No,
And why do you say that?
her oxygen saturation was adequate without it.
There's a big question in this case, Dr. Burdine, about, COVID-19. Was this COVID-19? You might even think that's the main issue in the case. I don't know. But it's been opening. I mean, yeah.
Go ahead.
What I want to talk about, Doctor, is why you believe that this is not COVID-19. And I think one of those things, correct me, is the imaging in this case.
So my opinion that's been stated is that there's no difference in the chest x-ray comparing the film on the 11th to the film on the 13th. And without a very sizable change in the chest x-ray image, you cannot attribute the massive deterioration in Grace's status to a progression of COVID-19.
Well, Doctor, in opening statements, attorney for the hospital did not testify, but attorney for the hospital stated that the imaging on the 13th showed further deterioration. Are you saying that you disagree with that?
Yes,
Okay. And do you interpret imaging as part of your practice?
every day.
Every day. How many images, how many x-rays or CT scans would you say you've interpreted over your lifetime?
Tens of thousands.
Tens of thousands. These are the imaging from October 11th and October 13th, and this might be a good time to get the stick.
I got the stick.
I know you do. What are we looking at here, Doc? What are we doing?
Okay.
Tell the jury what you want to, what's significant, what are we looking at?
May I?
Absolutely.
This film is from October 11th. This film is from October 13th. Now, both of these films are abnormal. You see all this white stuff that shouldn't be there. That is fluid inside of lung tissue. And you should normally just have air inside of the lung tissue. So this should all be dark. Now, the white or light stuff is not uniform. It's brighter in some areas and darker in some areas. So for example, the X-ray doesn't look so bad here. And if you look at this film, it doesn't look so bad here. Same pink here and here. And if you systematically look at all the areas of the lungs, the images are similar. And I do this every day, so I have a lot of practice at it. And it is my expert opinion that there is no significant difference in the lung fields of these two images.
Thank you, doctor. Thank you. I just want to make a record of the imaging. Here, this is exhibit 46, doctor. Just want you to take a look at that. It's hard to see because of the way it printed, but see if you can tell if those are those images we're looking at. If not, we'll have to get a better copy sometime.
Well, you're right. It's hard to see.
Okay.
We're going to need a better copy.
Well, it's okay. It's part of the.
What I'd like to do is maybe just give him the original exhibit 46 and see if that is any different.
Oh, yes. There you go.
Yeah, this is much better. These are the images that are up on the screen.
Now, there seems to be some disagreement maybe about what these images show. Were these images interpreted at the hospital?
Yes.
Okay. I'm handing you what's been marked Exhibit 47.
This is the radiologist's interpretation of the chest film on the 13th, and it indicates that the radiologist compared the chest film on the 13th with the chest film on the 11th.
And what were the conclusions?
Findings: patchy bilateral, mixed interstitial and alveolar infiltrates, unchanged.
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 Doctor, let's say hypothetically, if Grace's lungs would have continued to deteriorate, would it have been possible to see that on X-ray?
Yes.
Okay. We're not there yet. I think so. Have you had patients that have had worse X-ray imaging than what we've looked at here today?
Yes. So I've seen,
One second, doctor. Objection on relevance overruled. You can cross-examine him.
Doctor, I'm showing you here. Do you want to?
yeah,
Yeah, go ahead.
I have seen a large number of chest films from patients who had COVID-19. So if you have a scale of 0 to 10, with 0 being a normal chest x-ray and 10 being the worst film I've ever seen, Grace Schara's film on the 13th is a 5.
And tell us what we're seeing here, doctor. You can have mine.
Oh, yeah. Your Honor, may I use the stick again?
Yes.
So the left film is Grace Schara's image from the 13th. The right film is a patient that I took care of. And remember I said, if you look at this area here, it's pretty clear. Well, actually, there's nothing here because there's no tissue at all. There's all sorts of problems here. You can see, I mean, these are dense infiltrates. So this patient, I would rate this image as a 7. Grace's image as a 5. This one is much worse. This patient survived.
So before we move on, because I overruled the objection and I imagine you may want to cross-examine on it, but is that an exhibit, what is up on the screen right now?
Your
'Cause
Honor.
I don't have it.
Your Honor, that was included in the rebuttal report. That image was made a part of the rebuttal report. So
Okay.
Which I believe was received yesterday.
Understood, I did. It was 49, 50, and 51. So identify the page that it's on and you're talking the third report, which would be exhibit 51.
That's correct.
Okay. And then I'm going to just ask defense counsel to confirm that that's the same photo. And just so what I'm doing, members of the jury, is when somebody throws something up there and you're looking at it, I want to make sure everybody agrees. So when it gets taken down, defense counsel should have full access to bring it up when they're asking questions. And I want to make sure that we're all looking at right now, before it gets taken off the screen, something that's already been agreed to. So,
This is page 2, Your Honor, of the rebuttal report.
okay. And I think I'm looking at page 2 of exhibit 51, Mr. Guzzi and Mr. Prinkoviak, and it seems like that's it. You agree? You said yes, Mr. Guzzi, without that microphone. I appreciate it.
Yeah, sorry,
No, that's okay.
forgot to turn it on.
Mr. Frankowiak?
Yes.
Okay, and then, just so I'm clear, if they want to use this on their cross-examination, it's gonna be available for them.
Yeah, sure. It might take a setup, but sure.
Okay,
Yeah.
or,
What's the number of this one?
it's not marked as an exhibit, which is why I'm talking about it.
Your Honor, they should have an electronic copy of that report, so they should have the image if they want it.
Okay,
Well, I'm gonna ask for this because the report itself, the imaging is not as clear as what you have here. I would like these exact same images.
Sure, this was snipped right out of the report, but no problem, whatever you need.
I mean, if you can send, I mean,
I
I'm
can
gonna
send you
request
a
the actual
JPEG.
slide.
I can send you a JPEG.
We'll send you the slide. We'll send you the slide.
and what we're gonna do at the lunch break is we will mark that as a separate exhibit. So what you're looking at up on the screen will be printed off and marked as a separate exhibit, and it'll be available. Appreciate you guys doing that, and thanks for working it out. I don't want to make a bigger issue, but I wanted to address it before it got moved. Okay. Mr. Flight, are you a witness?
Can we do sidebar quickly?
Sure. So at this time, members of the jury, defense counsel has asked, and I think it's appropriate that we're just gonna excuse you again for a couple of minutes. We're gonna switch gears and get into one of the last lines of questionings of this witness. Is that right?
That's correct, Your Honor. We're almost at the end.
Okay, and before we do that, I need to do one thing that I didn't do. So it's kind of my fault, and you can't be in here when I do that one thing. So we'll get you can keep your notebooks here if you want. It's gonna be a short break, so be ready to come back in as soon as we ask for you. Jurors are excused. And then Bill, you'll stay here. All right, everyone may be seated. The sidebar was about you indicating you're gonna get into that learned treatise and other document. I said that was fine, as long as it's gonna be that one item.
Yeah.
Attorney Guzzi and Attorney Franconia, you talked separately and then said you would like to lay a foundation to it, I believe is what you said, Mr. Guzzi, in a separate void hour.
Yes, Your Honor.
Okay. And who's planning on doing that?
I'll do it, Judge.
Okay.
Thank you. Dr. Burdine, this article that you are,
Can we get him a copy?
oh, I'm sorry, I thought you had a copy for him already. So go ahead. I apologize.
And what was just handed, it has been marked as Exhibit 48.
Do you have that article in front of you?
Yes,
Mention to the authors of this article?
yes.
Do you know any of the authors of this article?
Do you mean know personally or know of them?
Well, let's start with no personally.
I do not know any of the authors personally.
Do you know any of the authors professionally?
I'm not sure what you mean by that.
Have you ever met any of the authors?
No.
Have you ever spoken to any of the authors?
No,
What can you tell me about the first author, Nin Win, I believe the last name is pronounced MD?
I can't really tell you much about any of the authors except the last author,
And who's that?
Dr. Amin.
What can you tell me about Dr. Amin?
Dr. Armin has published at least 100 articles in peer-reviewed journals. He has received a grant from the National Institute of Allergy, and those grants are very hard to get.
As far as any of the other authors are concerned, you don't have any additional information about in terms of whether they are considered experts in their field?
No,
Okay, thank you, doctor.
We ready to bring the jury in? Oh,
One
I'm
more,
sorry.
one
Yeah, I
one more
forgot.
question.
Yeah,
One more
go ahead.
question. Doctor, the name that you did recognize, what role or what part did that particular author play in the drafting or creation of that document, if you know?
the last author is generally the leader of the group.
Anything else?
No, Your Honor.
Nothing further.
He's gonna be able to testify to it. Okay, so they'll start bringing the jurors back in. All right, everyone may be seated. All right, I was able to do what I needed to do, and so I appreciate your patience with that. And Attorney Fleiter, still your witness.
Thank you, Your Honor. Doctor, during the brief recess, I handed you a document. So we're going to talk about that document, but it's important that you listen to my question and we don't go outside of the question. Could you please read the title of this article?
Outcomes and mortality among adults hospitalized with COVID-19 at U.S. medical centers.
And you testified yesterday. Oh, I'm sorry. Let's go back. Who published this article?
The Journal of the American Medical Association.
Okay. Have you heard of them?
Yes,
Okay. Can you explain, what that publication is?
well, the American Medical Association is an association of physicians in America. They publish a journal. It is considered a reputable journal. It's very widely read.
Understood. And you said yesterday that you prepared 3 reports in this case. Do you remember that? Yes. Okay. And the third one of those was your rebuttal report. Do you remember that?
Yes,
Okay. And did you reference this article in your rebuttal report?
yes.
Okay. Do you remember the exact words you used in your rebuttal report when you referenced this article?
See it.
Refresh your recollection if I handed you a copy of your rebuttal report?
Would make it much easier.
I'll do that for you.
And you can have the original Exhibit 51 if you want. No, that's. Okay.
Dr. Burdine, did you use a footnote to reference to this article there on page 1?
Want to make sure I get it right. Yes, it's reference 1.
Okay. And would you please tell us exactly what you said in your report regarding this article?
A study of 192,550 patients admitted to one of 555 U.S. medical centers with a diagnosis of COVID-19 between March 1, 2020 and August 31, 2020 found a mortality rate in the 18 to 29 age group of 1.4%.
How old was Grace, doctor?
19.
Doctor, I want to talk a little bit about your compensation in this case. What hourly rate are you billing at here?
I bill at $350 an hour for review of records and preparation of reports. I bill at $450 an hour for deposition, and I bill at $550 an hour for court appearances such as this one.
And when your invoices get paid, doctor, where's that money go?
Texas Tech University Health Sciences Center, Department of Internal Medicine.
How much do you get? What's your cut?
0.
Cut 0? Do you get a bonus from the institution or anything like that for doing these cases?
No.
Did your boss force you to do this case? No. So you're here serving as an expert, but you're not making a single dollar off this case, is that right?
That is correct.
Please tell the jury why you agreed to do that.
This case So as a background, since I came to Texas Tech University Health Sciences Center 16 years ago, all of the malpractice cases that I have testified in prior to this one were for defendants. I was defending physicians against malpractice claim. This is the first one where I've testified on behalf of a plaintiff. The reasons are because the breaches of the standard of care were egregious, and I could not live with myself without answering the call to review and give advice on this case. So during my testimony, we have gone through a number of things that I've identified as breaches of the standard of care. My reports are very long. The number of the breaches of standard of care I identify in my reports are too numerous to count, but some of them stand out. One was the manner by which the father, Schara, was evicted from the hospital and its impact on the outcome in Schara. And I found this to be shameful conduct on behalf of the hospital. The second issue were the breaches of standard of care related to informed consent. And I find it indefensible that this patient was given medications, very dangerous medications, not theoretically dangerous medications, but medications proved by the medical record to be dangerous to this patient without informed consent. The events on the 13th are very difficult to recognize. The repeated administration of Precedex on the 13th was not just a breach of the standard of care, it was insane. The administration, excuse me, the administration of morphine on 10/13 to a patient who was unconscious, unresponsive, had lost her blood pressure, had no palpable pulse, and whose respiratory pattern was screaming to anybody who would look, metabolic acidosis. The administration of morphine in that situation is or was the worst clinical decision I have ever witnessed in over 46 years of medical practice.
Thank you so much, Dr. Burdine. That's it for now.
Right, cross-examination, Attorney Frankowiak, you're going first. All right, go ahead.
Good morning, Dr. Burdine. Can you hear me okay with this microphone?
Yes,
Okay. Doctor, we can agree that there are no nurse practitioners or nurse anesthetists involved in this case, true?
correct,
Okay. And as you've testified, in terms of registered nurses, no registered nurse has a duty to obtain an informed consent for the administration or titration of a medication in Wisconsin, correct?
correct,
Okay. And in this case, every nurse who cared for Grace Schara was in fact a registered nurse, true?
if that's true or not.
Okay. And if any nurse, or if a nurse is not a nurse practitioner or nurse anesthetist, they do not have a duty of informed consent either to obtain consent for medication or consent for a DNR, true?
Correct,
You therefore have no opinions that any nurse in this case failed to comply with the standard of care relative to the administration of any medication or relative to the entry of a DNR, true?
Correct.
You have given the opinion that Grace experienced what you call overdoses of Precedex on the 7th and the 8th of October, true?
13th.
Okay. And the reason you believe that or the reason you call these instances overdoses is because you believe that anytime the level of titration of the Precedex went above 0.7, that constituted an overdose, true?
No, that's not the reason.
Okay. And you believe that Nurse Haynes, when he reached 7.7 on the first day as the initial titratable dose, that anything beyond that constituted or anything higher than that level constituted an overdose.
No, that wasn't my reasoning.
Doctor, for how long had Grace been wearing a CPAP mask at home prior to her hospitalization?
I don't know how long.
Okay. We can agree she was familiar with a CPAP mask and had in fact been wearing it for whatever period of time she'd been wearing that prior to the hospitalization, true?
Yes.
Okay. Doctor, do you have exhibit number 47 in front of you? I believe that was a radiology report that you had talked about.
Yes.
And this was the radiology report for the study on the 13th of October, 2021, true?
Yes.
This was, in fact, that radiology study for the 13th was one of the ones that we had up on the screen that you were looking at. You were comparing it to the chest film of the 11th, true?
Yes.
Okay. Doctor, if you look at exhibit 47, we can see this is in fact a radiology study of the abdomen for tube placement, is it not?
That's the label attached to it.
Okay. So that was not even a chest study that you were referencing and comparing to the 11th, true?
That's not true. The chest was clearly visible on the film.
Well, the doctor, the only question I'm posing to you is that is not a chest film, is it?
No, it is a chest film. The chest is visible on the film. Doesn't matter what the label says.
Okay. And you did not identify to this jury the fact that this was in fact an abdominal film that incidentally showed the chest rather than a chest film, did you?
I wasn't asked the question.
Okay. Well, you have been now, sir. And we can
Okay.
agree this is an abdominal film.
This is labeled an abdominal film. It includes the image of the lungs and the chest.
Okay. Doctor, we showed a comparison of a radiology film between one of Grace and one of an unknown patient of yours who was, I believe, 54 years old.
Yes.
Okay. And what were the comorbidities of that patient?
She was overweight.
Okay. Did she have COVID?
Yes.
Okay. Did she have a trach?
Yes.
Okay. Why did she have a trach?
Because she had been on a ventilator for an extended period of time.
As a result of COVID?
Yes.
Okay. So, and this was your patient?
I took care of this patient after she was discharged from the hospital.
Okay. And while she was in the hospital, I understand she was on a ventilator because of severe COVID disease and she lived, true?
Yes.
You, in fact, cared for a number of patients who had COVID, severe COVID disease, and who were ventilated and who lived, true?
Yes.
Doctor, you have treated COVID patients in the hospital as a consultant in pulmonology, true?
Yes.
Your role in treating patients with COVID at University Medical Center in 2021 was limited to providing pulmonology consultations, true?
Yes,
You do not have any formal certification or training as a toxicologist, true?
correct.
Okay. You do not have any formal certification or training as a pharmacologist, true?
Correct,
You are not board certified as a pathologist, true?
correct,
You are not board certified, licensed, or privileged to practice as a radiologist, true?
correct,
You've never written any articles specifically regarding the care of a Down syndrome patient in an intensive care unit, true?
correct,
You've never written any peer-reviewed articles concerning the treatment of Down syndrome patients who have COVID-19, true?
correct,
You've never written any peer-reviewed articles regarding the treatment of Down syndrome patients with acute respiratory distress syndrome, true?
correct,
You've not done any research pertaining to patients with Down syndrome who had COVID-19, true?
correct,
You've not done any type of laboratory research pertaining to the medication Precedex, true?
correct,
You've not written any peer-reviewed articles concerning the use of the medication Precedex as a long-term sedative, true?
correct,
You've not done any laboratory research concerning the use of Precedex as a long-term sedative in the ICU, true?
correct,
You've not done any research concerning the use of Precedex as a long-term sedative in a patient with COVID-19, true?
correct,
You've not written any articles concerning the use of Precedex as a long-term sedative in the ICU for a patient experiencing acute respiratory distress syndrome.
I'm sorry, can you repeat the question?
Sure. You have not written any articles concerning the use of Precedex as a long-term sedative in the ICU for a patient experiencing acute respiratory distress syndrome, true?
Correct.
You've not done any laboratory research with regard to the interaction of drugs such as Precedex, morphine, and Lorazepam, true?
Correct,
You've not written any peer-reviewed articles concerning the interaction of drugs such as Lorazepam, Precedex, and morphine, true?
correct,
You've not written any peer-reviewed articles concerning the proper dosage to be administered to patients for long-term sedation in an ICU setting, true?
correct,
You have actually never prescribed the medication Precedex to any patient, true?
correct,
Okay. You are unable to provide me with the specific names of any articles that you reviewed concerning the use of Precedex as a long-term sedative in the ICU when you testified at your deposition, true?
correct,
Okay. You were also not able at your deposition to cite to me any peer-reviewed articles or studies that concern the use of Precedex as a means to address delirium in the ICU, true?
correct,
As of 2021, you were not a participant or author of any standard of care applicable to a physician attending to a COVID patient in the ICU, true?
correct,
As of 2021, you had never been a participant in any writings or the author of any writings which identified standards of care as to the use of Precedex in an ICU setting, true?
no, that's incorrect.
Okay. Okay. Doctor, may I approach the witness, Your Honor? Doctor, I'm going to hand you what we have sealed copies of each of three versions of your depositions that were taken in this case. I'll just put them here. Please keep those in case we need to reference those as we go along. Package for the first deposition that we took, which would be number 1.
Is it the one on the top?
I believe so. It would be the first date of your deposit, the date of your first deposition.
December 13, 2024?
I believe that is correct.
And let's mark that as an exhibit. So what exhibit is that? And the clerk will put a exhibit sticker on it. So if you can tell us which one, and yes. Our reporter will read that back as we're trying to figure out which exhibit.
As of 2021, you had information that a participant in writings or the author of writings which identified standards of care as
Oh, as of 2021, I missed that part of the question.
Okay.
Oh, as of 2021, no.
Okay, so the answer, as of 2021, you had never been a participant in any writings or the author of any writings which identified standards of care as to the use of Precedex in the ICU. The answer is no.
The answer is no.
Okay. Doctor, you are not a nurse, obviously. You have never attended nursing school.
No,
You have never been credentialed in any state as a nurse.
no,
You have never been employed or worked professionally in the capacity of a nurse in the ICU.
no,
You have never testified at trial or deposition on the standard of care applicable to a nurse in an ICU setting.
I don't think so.
Okay. You did not do any research relative to the standard of care applicable to nurses in order to prepare your opinions in this case.
Correct?
You did not review any documents, treatises, or book chapters relative to the standard of care applicable to an ICU nurse in preparation for your opinions in this case.
No,
Obviously, nurses would have training and education that would differ from that which you have received. True?
correct?
And the typical job duties of a nurse in an ICU would differ from those of you as a pulmonary consultant in the ICU. True?
Correct?
Nurses are not qualified to render medical diagnoses. True?
I don't think that's true. Nurses form opinions about what's going on all the time, and their training qualifies them. Is their training the same as a physician? No.
Okay, if you could open volume 2 of your deposition, that would be the one labeled January 4th, 2025.
Exhibit that is
Sure.
24. All right, so I'm gonna have the clerk put exhibit sticker 424 on that second of 3 deposition. No, Andy, the one he told me. And so I just want to make sure we're all on the same page. Yes, so there are going to be 3 different exhibits. And the one that we just identified as 424 is the one that the witness is looking at. Is that right, Attorney Frankowiak? That's what you
Yes.
asked for? Okay.
Yes. Okay.
I'm sorry. We can talk about that. So exhibit 424 is in front of you, Doctor.
Yes.
Yes.
You could go to page 307 of that transcript, please. When you're there.
I'm there.
Okay, I want to start off at line 23 there, and I'm asking you a question, and it says as follows. The question is, would you agree with me that nurses are not qualified to render medical diagnoses, whether they try to do so or not? And it continues on to page 308. And your answer to that question was correct. Did I read that correctly?
Oh, okay, yeah,
Okay. Nurses or medications are prescribed by physicians, true?
correct,
And registered nurses cannot prescribe medications.
correct,
Registered nurses are in fact not qualified to prescribe medications, true?
correct,
It is physicians who enter orders into a patient's chart.
um, I think nurses sometimes enter orders as well, but physicians enter orders.
Right.
If you're talking about orders for medications, um, physicians are generally the ones that do it. Sometimes there are verbal orders which are actually entered by a nurse receiving the verbal order.
The orders in those cases for medications originate with the physician, and they may be written in the actual chart by either a nurse or a doctor, true?
Correct.
If you enter an order in a patient's chart that you believe to be accurate and helpful for the treatment of the patient, is it your expectation that the nurse with whom you are working will follow and implement that order?
Yes.
It is beyond the scope of a nurse's expertise and professional competence to prescribe the medication Precedex, true?
Yes.
It is beyond the scope of a nurse's expertise and professional competence to prescribe the medication Lorazepam, true?
Yes.
And it is beyond the scope of a nurse's expertise and professional competence to prescribe the medication Morphine, true?
Yes.
Any opinions you advance in this case as to the prescribing of medications are not opinions that are directed to the nursing staff of St. Elizabeth Hospital, true?
Correct.
You are not advancing in this case any opinions that any of St. Elizabeth Hospital's nurses fell below the standard of care as a nurse in the administration of any medications to Grace Schara, true?
Correct.
At your hospital in 2021, you are not, or you were not typically treating patients who were the sickest of the sick relative to COVID, were you?
Well, it's hard to define what's the sickest of the sick.
Okay. Well, doctor, you told me at your deposition that you personally were not typically treating patients who were the sickest of the sick, true?
Typically, no.
You were treating patients after they had gotten well enough so that they were no longer needing ICU level care.
No, I don't think I said that. I believe what I said. At our institution, we have a number of teams in the pulmonary division. We have an ICU team, we have a consult team. Our ICU operates as a closed ICU. So if you are admitted to the ICU, then you have an attending physician who's a pulmonologist. So who's also on the ICU team. So there's no reason to get a pulmonary consult if your attending is already a pulmonologist.
Okay. And you were the consulting pulmonologist in that scenario.
Yes.
Okay. As opposed to the individual who was actually treating and following the patient while they were in the ICU, true?
Well, I was treating and following patients who were in the ICU. They just weren't on the ICU team.
Mhm. Doctor, you were initially made aware of this lawsuit by way of an email, true?
Yes.
Okay. You were part of an email group called C21X, which is a group of people who disagreed with the official narrative on matters related to COVID, true?
Yes.
And you used to participate and contribute things to this email group, true?
Yes.
At some point, a woman named Catherine Quagg sent an email to that group asking if there were any physicians with training in pulmonary or critical care who might like to help as an expert for Mr. Schara in his lawsuit. True?
I think you mispronounced her name.
Okay. Certainly, if you can correct me and as to the
Oh,
pronunciation.
how is the last name spelled?
Quag, according to
No,
transcript.
it's not a Q. Her last name starts with an H. I don't recall how it's spelled.
Okay. And you had apparently mispronounced the name initially when we had this conversation at your deposition?
I don't think I mispronounced it. Maybe it was misheard.
Well, doctor, the question is, at some point, a woman, this Catherine, sent an email to the group asking if there were any physicians with training in pulmonary or critical care who might be willing to help Mr. Schara as an expert in his lawsuit. True?
No, the email did not mention Mr. Schara at all. The email said, were there any people in this group with training in pulmonary and critical care who would be interested in looking at a case related to COVID?
Mhm. Well, doctor, if you could pick up the transcript for your first deposition, the December 13th transcript. And I'm referencing page 109. Okay, are you there?
First deposition.
This is the first
All
deposition.
right. So which exhibit is this going to be, counsel? Art 424. Okay, so we'll mark this as exhibit 425, and that's volume 1.
Yes.
The clerk put exhibit sticker 425 on that front of the exhibit, doctor, before we start testifying about it. Dr. Burdine, do you mind if she just puts a sticker on the front page? All right, go ahead, Attorney Frankowiak.
Okay. Doctor, at page 109, are you there?
I'm on page 109.
Okay, starting on line 2, we were having a conversation and your words to me in answer to my question were as follows, starting at line 2. Anyway, Catherine Quagg, spelled Q-U-A-G, and then there's an indication that it was spelled phonetically by the court reporter. And I'm probably mispronouncing her name, and I can't spell it, sent an email to the group asking if there were any physicians with training in pulmonary and critical care who might help with this matter or help with the matter. Did I read that correctly?
You read that correctly.
Okay. And you responded to Catherine Quagg, and she arranged a Zoom meeting between yourself, herself, and counsel for Mr. Schara, and they told you about the case.
Yeah, I did not know it was counsel for Mr. Schara. I just knew he introduced himself as Mr. Fleiderer.
Okay. I'm done referencing the transcript, sir, but we'll go back to it if we need to. This group that you belonged, C21X, disagreed with the official narrative of COVID, I believe is the way you described it to me, yes?
Yes,
For example, they disagreed with the official position taken on various medications, true?
yes,
And they disagreed about the official narrative on vaccines, true?
yes,
And they disagreed on a lot of hospital protocols, true?
yes,
And the biggest disagreement that the participants in that group had was substantial opposition to the isolation of patients from families that had been required by the CDC, true?
I don't know if that was the biggest one, but that was a significant one.
Okay. And you became involved in this group, C21X, because you had been involved in a lawsuit that a restaurant owner brought against the Canadian government over lockdowns, true?
Yes,
Okay. And other people involved in that suit gave your name to the person who runs this group, who included you in that texting group.
yes,
Okay. And during the time of the COVID pandemic, it was a protocol recommended by the CDC to isolate patients in the hospital from their families, true?
I'm not sure the protocol came from the CDC or not.
Your hospital had a protocol recommended by the CDC to isolate patients in the hospital from their families, true?
Yes,
Okay. And you have publicly spoken out against the CDC's policy of isolation of COVID patients, true?
yeah, again, I'm not sure it's the CDC's policy, but I spoke out against the policy at my institution.
Okay. You do not hold any opinions on the standard of care applicable to any nurse in this case, other than Nurse Allison Barkholtz, true?
Yes,
And she was the charge nurse who asked Mr. Schara to leave the hospital on the morning of October 10th?
I think ask is mischaracterization. She ordered him to leave.
Okay. Obviously, you've given a lengthy deposition that lasted over 3 different sessions in this case.
Yes,
Okay. And you had told me during the course of the deposition that you had reviewed the depositions of a number of individuals, except for that of one nurse. True?
all,
In your third deposition, you identified the nurse whose deposition that you had not read before authoring your report as the deposition of Nurse Holly McGinnis. Do you recall testifying to that effect?
correct.
No,
And
1 second, doctor.
I want to put an objection on that. We're just reading right out of the deposition instead of asking questions. It's not an impeachment at this point, and so we should ask the question, and if he contradicts, then he can read the depo.
Doc, which is. Sure, absolutely, absolutely. I'll just rephrase the question, Doctor. At the time of your authoring of any of your opinions in this case, in any of your reports, you had not reviewed the deposition of Holly McGinnis, had you?
question,
The time that you wrote your report, your initial report and your second report in this case, you had not reviewed the deposition of Holly McGinnis.
so I don't know when I reviewed the deposition of Holly McGinnis. It was sent to me in a format that I could not read, so I could not actually physically read the deposition. Eventually, Mr. Fleiderer corrected that problem, and I was able to review the deposition of Holly McGinnis, but I don't recall exactly when that date was.
Okay, Doctor, and at the time of your final deposition in this case, which was held on January 20th of 2025, you had already authored your opinions in this case?
Some of them,
You had authored 2 full reports, correct?
I can't recall the timing of the reports and the depositions.
And at the time of that last deposition that you gave, the third of 3, you had not yet reviewed the deposition transcript of Nurse McGinnis, had you?
I would have to look and see. I may be able, no, I wouldn't be able to do it even from that. I can't recall when I reviewed the deposition of Holly McGinnis.
Okay, I'd like to reference the transcript if we could. It would be your third one. So this is the last of the 3 that has remained unopened.
426 on that document.
I want to object to that. The witness testified he does not remember. If counsel wants to refresh his recollection with the deposition, then I think that would be appropriate.
Agree. Have him refresh his recollection by looking at a certain page.
Absolutely fine.
Oh, you need this? Yeah.
Okay. Doctor, I would refer you to page 622, and then there's a portion that goes on to page 623 of that volume. Let me know when you're there.
Just so the jury knows, there's a process that if somebody says, I don't know, you can use, I think we explained this earlier this week, but attorneys are allowed to show them something to refresh the recollection. And it's not an impeachment. So after the doctor looks at pages 622 and 623, he'll close that exhibit. And then the counsel's going to say, did that refresh your recollection? And
Jason,
see what happens with it.
Yeah,
So
page 622.
whenever you're done, doctor, reviewing those pages, you just close it and let us know that you're done.
Done.
And now you got to close it.
Okay. Did you read page 622 and 623?
I read the relevant material.
Okay, I'll re-ask the question then. As of the time of your third deposition on January 20th of 2025, you had not yet read the deposition of Holly McGinnis, true?
Correct.
Okay. During the course of your career, you have attended to and cared for patients that ended up passing away, true? In critical care, in fact, that is not an uncommon event, true?
Correct.
Sometimes even when provided with medical care that meets the standard of care, patients still pass away, true?
Correct.
During the COVID pandemic, there were patients who, despite receiving treatment that met the standard of care, still passed away as a result of COVID, true?
Correct.
You do understand and believe that there is a COVID virus, true?
Correct.
And you believe that the COVID virus caused a great deal of illness and caused a significant number of people to die, true?
Correct.
And there were a significant number of people, in fact, who died from COVID-related acute respiratory distress syndrome in your own hospital at Texas Tech, true?
Correct.
You would agree that this country experienced a pandemic relative to COVID in 2020 and 2021.
Correct.
Because it was a worldwide pandemic and because it was something that institutions were trying to figure out while it was going on, you believe that it was fair that different hospital institutions were handling COVID admissions in a different fashion, true?
I think that some of the decisions made on how to handle COVID were made by reasonable people who had good intentions. And some of the decisions, that's not true.
Okay. Doctor, if you could reference the first version of your deposition, the December 13th copy.
I've got it.
Okay, I would like to reference page 116. Let me know when you're there.
I'm there.
Okay, I'm going to read the question starting at line 11, and it states as follows. As far as the admissions for COVID, because it was a worldwide pandemic and because it was something that institutions were trying to figure out while it was going on, would it be fair to state that different institutions were handling COVID admissions in a different fashion? Answer, yes. Did I read that correctly?
You read that correctly.
Okay.
I'm not sure if that's the same question you asked me, but I agree with what's in the deposition.
Okay. As far as COVID admissions that took place at your own institution at Texas Tech that resulted in the death of a patient, you are not of a philosophy that those patients all received substandard care, true?
Correct?
Okay. In fact, you believe that healthcare providers who rendered treatment to COVID patients during the COVID pandemic did the best that they could do, true?
Well, some of them did and some of them didn't.
Okay. In general, people did the best that they could do to care for the patients during the COVID pandemic, true?
Tell what you mean by in general.
Mhm. That's why I was asking you, because that's what you told me in your deposition, sir.
Okay,
You-
since it's been followed up, I'm
And
gonna
they have to see,
hold on.
If there's attorneys talking, please don't talk.
Okay.
Okay, the court reporter is taking down one of us. The objection sustained. Don't do that, Mr. Frankowiak.
Why don't we reference page 116 of your transcript?
which one?
The first one.
Page which?
Page 116, please.
Yeah,
Okay, are you there?
I'm there.
Okay, I'm going to reference a question that begins on line 18. The question states as follows. Okay, as far as the COVID admissions that took place here at, and then you interjected at my institution, and the question continued, yeah, at your institution, that resulted in the death of a patient, you're not of a philosophy that those patients were all received malpractice or received substandard care? Answer, oh no, I think the care, I think in general, people did the best they could do. Did I read that correctly?
You did.
Okay. We can agree that COVID was the cause of death of many patients throughout the country in both 2020 and 2021, true?
Yes.
And COVID was the cause of the death of many patients in your own hospital in both 2020 and 2021, true?
Yes.
COVID was a serious infection that was life-threatening for a certain percentage of the population, true?
Yes.
As a pulmonologist, you understand physiologically how COVID affects the lungs, true?
Yes.
Okay. COVID affects the lungs for a number of patients in such a way that those individuals did not survive, true?
Yes.
If a patient died from COVID affecting the lungs, it's because they had acute respiratory distress syndrome, or ARDS, ARDS, true?
Yes.
ARDS is a syndrome that has many causes, and COVID pneumonia is one of them, true?
Yes.
ARDS caused by COVID pneumonia is characterized by a capillary leak where the capillaries in the lung and other tissues become permeable to proteins, whereas normally proteins do not leak out of the capillaries.
That's true.
Okay. Because the proteins leak out of the capillaries, there's no longer an oncotic pressure gradient from the vasculature to the interstitial tissue, and you end up with a lot of edema in those tissues, true?
Correct.
And edema means swelling.
Edema means, it doesn't mean swelling, it means the leakage of fluid.
Okay. And this edema causes problems, true?
Sometimes.
Okay. Edema, in fact, has to do with the transudation and exudation of fluid from the vasculature into the tissue or the interstitium of the tissue, true?
True.
In the case of pulmonary edema caused by COVID, you have water where it doesn't belong, true?
True.
Instead of water being in the blood vessels, it is instead in the interstitium of the lungs, true?
True.
As a result, the lungs become stiffer, so it's hard to inflate the lung, true?
True.
This process is happening in a very non-uniform manner, which causes VQ mismatching or ventilation perfusion mismatching, true?
True.
With a patient who's experiencing this process where edema is affecting the oxygenation of the patient, you would expect to see radiographic changes, and you would notice that the patient was experiencing oxygenation problems, true?
True.
Doctor, I believe you said you've reviewed Grace Schara's medical records?
Yes.
Okay. And you've also, I believe you said you've reviewed a number of depositions, including that of Scott Schara?
Yes.
Okay. You recall reading Scott Schara's deposition testimony on the subject of intubation, true?
Yes.
You understand from reviewing this testimony that Mr. Schara would not have consented to the intubation of Grace for the purpose of placing her on a ventilator under any circumstances during her hospitalization at St. Elizabeth Hospital. True?
Proper witness for that testimony. He's not here to talk about what Scott Schara testified to in deposition.
I'm sorry, was there a?
Sustained.
Okay. Mhm.
Explain to the jury sort of what my ruling was, and it's been consistent throughout, and and I think I've said this, but it's good to hear it again. So throughout the trial, because there's a sequestration order, I have ruled to the attorneys that they're allowed to tell a witness what somebody else has testified at this trial when the witness is here. So if the question is, at trial, Mr. Schara testified to A, and as long as A is accurate. And the reason I'm limited to the trial testimony is because all of you will remember what that witness testified to. And then you'll be able to hear what expert witnesses think of that testimony to the extent that it's relevant to this case. But the question that was asked, and the reason that I sustained it, is because Attorney Frankowiak was talking about Mr. Schara's deposition testimony. And so during the sidebar, I said, we're not talking about deposition testimony because the jury has heard trial testimony. And if Mr. Schara would have said something in his deposition that was inaccurate, then you can impeach him on it, which happened. It didn't happen, but it happened where you heard deposition testimony. But when we're telling witnesses what somebody else has said, it's going to be what they said at trial, especially if that person has already testified. So go ahead, Mr. Frankowiak.
Thank you, Your Honor. The hospital in which you worked at Texas Tech had ventilators in 2020 and 2021, true?
Yes,
And your hospital at Texas Tech utilized ventilators in the treatment of patients who had COVID in both 2020 and 2021?
yes,
Ventilators would be used if non-ventilator care was inadequate to maintain carbon dioxide and oxygen levels that were considered necessary, true?
yes,
When you were treating COVID ICU patients in 2021, some patients would get worse very slowly and others would get worse more abruptly, true?
yes,
When you had a situation where someone got worse, a lot worse abruptly, you would go to a ventilator earlier than you would in somebody who was getting worse slowly, true?
So go to a ventilator is a difficult term. I think you would recommend a ventilator. Whether the patient agreed to it or not, it's another story.
Okay. And this was because you were concerned that the patient might be so bad that they will require the ventilator at an inopportune time, true?
True.
Amongst the patients that you were treating in your hospital in 2021, there were some patients that without the ventilator could not maintain adequate levels of carbon dioxide and oxygen, true?
True.
For a patient who is unable on their own to maintain adequate levels of carbon dioxide and oxygen, that can be a life-threatening situation, true?
True.
A ventilator is not a treatment per se, but instead acts as a bridge, true?
No, I think it is a treatment. It also acts as a bridge.
Okay.
I think it's both.
And in using a ventilator, you're attempting to keep the patient alive long enough for your other treatments to work, true?
Well, that's one reason.
Okay. When you were treating your own patients in 2021 at your hospital at Texas Tech, you made recommendations or issued orders for one or more of your patients to be ventilated, true?
Correct?
In the case of the COVID patients on whose care you participated in your hospital in 2021, it was your goal to preserve your patient's life to the extent that you were able to do so successfully in order to treat the patient's COVID, true?
True.
When you would order a patient placed on a ventilator, it was your goal to preserve that patient's life to the extent that you were able to do so, true?
True.
When you treated patients for COVID, you would not recommend or order placing a patient on a ventilator unless it was necessary in your view as the physician to preserve that patient's life under clinical circumstances that you considered necessary, true?
True.
Ventilators did indeed play a role in the treatment of patients suffering from COVID in your hospital in 2020 and 2021, true?
True.
And it's true that ventilators played a potentially useful role in treating COVID patients in all hospitals in 2020 and 2021, true?
I don't think I can testify about all hospitals.
Okay. The mortality rate for those COVID patients who were placed on ventilators in your hospital was approximately 50%, true?
More like 40, but
Do you believe at your hospital the mortality rate was 40% for COVID patients?
no, not for COVID patients on ventilators.
Okay. And a mortality rate of 40% means that 60% of COVID patients placed on ventilators in your facility lived, true?
Correct?
Generally, it was the sickest patients who were placed on ventilators in your hospital, true?
True.
Some patients with COVID develop acute respiratory distress syndrome, and those patients do get sick, true?
True.
Some of the patients who developed ARDS required ventilators in their care that you were participating in, true?
True.
To your understanding, Mr. Schara, while he was present with his daughter at St. Elizabeth Hospital in October of 2021, was not wearing any type of personal protective equipment, true?
That's according to his testimony.
Okay. To your understanding, all of the caregivers who were caring for Grace at St. Elizabeth Hospital in October of 2021 were wearing personal protective equipment, true? The caregivers and the nursing staff in your own hospital in 2021 wore personal protective equipment when they were in a COVID room in the ICU, true?
True.
There was a belief that in 2021 that wearing personal protective equipment reduced the likelihood that a person would contract COVID, true?
Question, there was a belief. I think that's very vague.
Can you just,
Sure. Doctor, you were obviously treating patients during the COVID pandemic in 2020 and 2021, true?
Yes.
Okay. And you understood that there was a belief amongst healthcare providers that you recognized that wearing PPE reduced the likelihood that a person would contract COVID.
Some providers had that opinion.
You are not able to identify any hospital which did not require caregivers to wear personal protective equipment in a COVID ICU room in 2020 and 2021, true?
True.
One of the reasons that caregivers, including nursing staff, were required to wear PPE was so that they themselves would not become infected, despite the fact that they were having repeated close contact with infected individuals, true?
Well, that was the intent. Whether it worked or not is debatable.
Okay. There is evidence that some workers wearing personal protective equipment who were in close proximity to COVID infected patients did still become infected.
Your Honor, I want to object there to the use of the word evidence. In this case, there's, to my knowledge, been no such thing.
Sustained.
Doctor, would you agree that some workers wearing personal protective equipment who were in close proximity to COVID infected patients did still become infected?
Yes.
Okay. You would agree that there's strong evidence in the literature that the use of monitoring devices in an ICU setting, if properly used, would prevent a significant number of deaths and injuries, true?
Foundation on that question, he's not identified any literature, and the concept of in the literature is too vague.
Okay.
Please.
There's strong evidence in the literature that these monitoring devices in ICU setting, if properly used, prevent a significant number of deaths and injuries.
Literature that's accepted in the medical field.
Mhm.
Attorney Frankoliak,
I can rephrase that
Okay.
was,
then
okay.
go ahead.
Doctor, you would agree that the use of monitoring devices in an ICU setting, if properly used, would prevent a significant number of deaths and injuries, true?
Yeah, the key is properly used.
Okay. The reason you have alarms in an ICU room is because even if some are false alarms, there's always a possibility that one or more of the alarms will not be a false alarm, true?
I have to repeat the question.
Sure. The reason you have alarms in an ICU room is because even if some are false alarms, there's always a possibility that one or more of the alarms will not be a false alarm, true?
I don't know if that's the reason, because I'm not the one who determines whether they have alarms or not.
Okay. If you could refer to your deposition volume number 2, which is the January 4th version of that deposition. Let me know when you're at page 431.
I'm there.
Okay. I'm referencing page 431, the question that begins at line 13. That question reads as follows. Okay. And the reason you have alarms on is because even if some are false alarms, there's always a possibility that one or more of those alarms will not be a false alarm. Your answer was, that's correct. The alarms are there for a reason. Did
Yeah,
read
I
that
don't think
correctly?
that's the same question that you asked me, but I agree with the question and answer as stated in the deposition.
Okay, we can agree that alarms in an ICU room are indeed there for a reason.
Yes,
Okay, the reason for alarms in an ICU room is to help the healthcare providers and nursing staff stay on top of the patient so that they don't miss an important change in the patient's condition. True?
yes,
In the ICU of your hospital in 2021 at Texas Tech, when you were treating patients, there was never a period of time when all alarms were turned off in a patient's ICU room in order to help that patient sleep. True?
all alarms, no, that was never done.
There are in fact many alarms in an ICU room. True?
There are many alarms, yes.
There are alarms on every IV pump. True?
Well, the continuous view, yeah, the pumps, yes,
There are alarms on the pulse oximeter, true?
yes,
There's an alarm on the heart rate monitor, true?
yes,
There's an alarm on the blood pressure monitor, true?
yes,
Heart rate, breathing rate, and oxygenation are all things that are important to keep tabs on, particularly overnight for a patient in the COVID ICU, true?
yes.
The- We certainly could, sure.
All right, you may be seated. And Dr. Burdine, you can step down, and if you can be back here at 12:30 or so. All right, thank you. I think just one thing I want to say, and I think Dr. Burdine just said it, and it's been happening more than it should. Attorney Frankowiak, is if you're going to impeach by use of a deposition transcript, make sure the question that you asked here is not different than the question in the deposition. Understood?
Yes.
Okay, and that's, last warning, the next time you do that, I'm gonna let the jury know that it's inappropriate. I had warned you separately. But I think it's been repeated. I mean, there's so many times in this case where all of a sudden, when you read the deposition transcript, I go, oh, that was different than what you had just asked. And it might just be one word or one slant, but if you're gonna impeach somebody, I think on their prior testimony, then, and it's similar to the letter that Attorney Guzzi had written on behalf of the doctor that he signed off on. It better be inaccurate. Make sense?
Yes.
Okay, so we had a sidebar. I think I explained the sidebar to some degree to the jury, but does anybody want to comment on that sidebar?
John Slater for plaintiff, no, Your Honor.
Attorney Frankowiak, anything? Attorney Guzzi?
Want to clarify what I was referring to. There have been circumstances in this trial where plaintiff's counsel or the witness has made reference to testimony by Jessica. That's what I was alluding to with that clarification.
I don't think you said that during the sidebar.
I did not.
Okay, so let's just explore now that that's a new issue. So plaintiff's counsel referred to Jessica Vanderheiden's test statements, okay?
I believe that no, it's been a long, not the transcript in front of me, but my memory is that may have happened.
With this witness, you're saying?
I'm not sure about this witness.
Okay. So why would that cause an objection on the issue? So the question in this case had to deal with Mr. Schara's deposition testimony. And so I don't think anybody brought up Jessica Vanderheiden's deposition testimony in a question to then have this witness use that information to answer a question.
No, it was just more of a thought question as to how other questioning has gone in terms of referencing depositions. If I'm incorrect on that.
Okay, so I want to maybe just make sure we understand, I think when I hear a question that, Dr. Burdine, during the deposition testimony of Mr. Schara, and then Mr. Franconiak, you went forward. I was sitting up here going, why are we talking about the deposition transcript of Mr. Schara to this witness? That was my concern during the sidebar. I think the focus, because first of all, I'm not sure that that question that you asked, I told you during the sidebar, I think it was a misrepresentation or a misstatement. And then I said during the sidebar, I corrected myself because I said it definitely was a misstatement from what his trial testimony was. And I don't know what he testified to in his deposition testimony. And so I hate a suggestion where somebody's misrepresenting something. And so I'm going to order that everybody just stick to the trial testimony. And if you're going to refer to Mr. Schara's trial testimony, then you can do that. And the jury will be, I think, smart enough to know if you're misstating it, or they can use their collective recollections. There could be an objection, and if you are, then I'm going to sustain the objection. But I think the referral back to deposition of somebody else's deposition transcript just doesn't make sense. So that was the basis of my decision. That's been consistent since the beginning of the trial. And I can't imagine somebody referenced, it maybe in opening statements, they said, this is what somebody's going to say. Or I think Mr. Schara said, Jessica told us this was happening at the hospital in live time on October 13th. And that's fair. He wasn't referring to what she testified to at a deposition. So that was my concern during the sidebar. And I just encourage everybody not to do that. Both sides. Okay. And then if you do it, just make sure it's accurate. Okay.
Your Honor, I just have a point of clarification. We were running into this issue with the impeachments yesterday. We did, I think, a couple sidebars because we had some inaccuracies, and our plaintiff's position was that they weren't proper impeachments. You said, I believe, something to the effect of, well, you can do it on cross-exam. So I think we stopped objecting to the improper impeachments on that basis. Is it the court's position now that we are able to object? The court would accept objections at that time and rule from the bench?
I lost you. And I never tried to tell you, any of you guys, not to object.
You're right. And that's a misstatement, Your Honor. Your position on the improper impeachments was, well, you can cross-examine, and then you allowed the impeachment to continue.
And what witness are you referencing?
This would have been under Cindy Schara.
Okay.
My question is, we took from that, okay, well, the court wants us to just do this on cross.
Your direct examination of Cindy Schara.
Or sorry, redirect. The court would want us to do this on redirect. And the question is, at this point, are you going to stop the improper impeachment if it's inaccurate, or should we still just rely on redirect?
Well, I think back on Tuesday on that issue, you kept objecting, and you cited the rule of completeness, if I remember correctly. Is that what you were doing?
That was Attorney Boylan, but yes.
That's a different objection than what I'm trying to suggest.
Understood.
So under the rule of completeness, I think the proper approach is we don't interrupt their cross-examination. You just clean it up on your redirect.
Got it.
What I think I was referencing now is just a different rule that I don't know if it had anything to do with impeachment. It had to do with if you state something, it should be accurate.
Yeah, understood.
Okay,
Judge,
so
thanks.
if somebody says something on page 66, but then the rule of completeness, you want to get into page 67, that's different than asking a question. And when that witness says, no, I didn't do that. And then you give them the deposition transcript, and that question is different than the one that they had previously answered. That's not a proper impeachment. It's just, and I think Dr. Burdine just said it at the end, like, you asked me a different question. And it's true, you had asked him a different question, and that's been sort of a trend. And I think you just moved on because you probably realized it was a different question. And if that's the case, then I think it was improper for you to do it, Mr. Franconiak. And if Dr. Burdine was wrong and it was the same question, then I think you should have nailed him on his answer. You could have the court reporter read it back and then compared the deposition transcript, and I think all of us would have said, well, those were two different questions. So the warning that I'm giving now is just don't do it. Both sides, okay? Different than the completeness. Okay, anything else from the plaintiff on any of that?
No, Your Honor.
Anything from defense on any of that?
No, Your Honor.
So 424, 425, and 426 are the deposition transcripts from the doctor, and then 43 through 48 have been referenced either on direct or cross. Any objection to those 9 exhibits being received?
None from plaintiff.
Attorney Frankowiak? Okay, so those 9 exhibits are received. How much longer do you have approximately?
Maybe half an hour, maybe.
Okay, and then Attorney Guzzi, you said,
Covered a lot of what I thought was covered, so,
okay, so then you guys should be ready for your redirect, and we'll do the redirect, and depending on how that is, we'll have the jury questions and see where we're at. 40 minutes from now, enough time for everybody? Okay, we'll see you at 12:30. We're adjourned.
No, I don't.
Okay. Dr. St. Elizabeth had a policy in October of 2021 which permitted the removal of any person whose actions were disruptive or who might otherwise adversely affect patient care, did it not?
Objection, Your
Said
Honor.
I don't know.
Okay. St. Elizabeth Hospital had a policy in October of 2021 which temporarily stopped in-person visitation consistent with CDC guidelines during the COVID pandemic with limited exceptions, did it not?
They had a policy that denied entry into the hospital of people who had signs and symptoms of COVID. They also had a policy that, as best I can tell, applied to employees who exhibited signs and symptoms of COVID, but neither of those policies would have applied to Scott Schara.
Okay. St. Elizabeth had a policy in effect in October of 2021, which required any visitor who fell ill while visiting the hospital to report this fact to the hospital staff and then depart the hospital immediately. Did it not?
Objection, hold on. Objection to foundation on that question, Your Honor.
Okay. Did you review any policy of St. Elizabeth, which required a visitor who fell ill while visiting the hospital to report this to the hospital staff and then depart the hospital immediately?
I've never seen that policy.
Okay. You arrived at your opinions in this case without reviewing such a policy?
Well,
Hold on.
go ahead.
Foundation. We haven't established what policy we're talking about.
Okay.
Yeah, so the objection sustained.
Okay, I can follow up. Doctor, did you review any hospital policies relative to visitation prior to formulating your opinions in this case?
The only policy that I saw was the one given to us very belatedly after many, many months of request. And that was the policy that he was removed because of his signs and symptoms of COVID. But all I have heard are there have been experts from your side who have testified about some poster. I have never seen the poster. I've never seen the policy the poster was based on.
Okay, thank you, doctor. During the COVID pandemic, hospitals were routinely modifying their standard patient visitation policies, true?
Objection, vague foundation.
Sustained.
Doctor, it was a widespread occurrence that institutions were modifying their standard visitation policies during the pandemic, true?
Same objection.
Go ahead.
True.
In 2021, St. Elizabeth Hospital was a private hospital.
I don't know.
Okay. Doctor, if you could reference page 147 of your deposition, please.
Which one?
I think that's the December 13th one.
Which
Page-
page?
Page 147, please. Starting at line 5. Let me know when you're there.
Okay.
Okay, at line 5, there's a very short question that asks as follows. St. Elizabeth Hospital was a private hospital, correct? And the answer to that question was yes. Did I read that correctly?
You did.
Okay. As a private hospital, St. Elizabeth Hospital had the right to decide who was to be on premises and who was not.
Yes.
Okay. Your own hospital at Texas Tech also had the right to do this, true?
Yes,
You've never personally written any guideline as to who gets to stay on the premises of a hospital and who does not, true?
true,
You've never authored any document on the standard of care dealing with who gets to stay on a hospital premises during a pandemic and who does not, true?
so I wrote an article. I don't know when this article was written relative to my depositions. But I did write an article that was critical of the decision to deny access to family members during COVID.
Okay, and that was an article that was expressing your opinion that you did not believe it was appropriate or right to deny access to the families of COVID individuals?
Correct.
Okay. In terms of the previous question I had asked, it's true to state that as to the standards of care as to who gets to stay at a hospital during a pandemic and who doesn't, that's not something you've ever authored, true?
True.
We can agree that Mr. Schara was not at liberty to engage in any conduct that he wanted to, and yet still have an expectation that he would be able to remain on the hospital premises, true?
Objection, foundation. Sustained.
Yeah. Doctor, do you believe that Scott Schara was at liberty to engage in any conduct that he wanted to and to have an expectation that he would be able to remain on the premises in October of 2021?
No.
In 2021, you were not in a position to decide the policy of your own institution at Texas Tech as to who got to stay on the premises and who did not get to stay on the premises during the pandemic, true?
Objection, foundation.
Go ahead.
True.
Okay. A hospital does not have to tolerate a family member who is abusive to the staff, true?
Objection, foundation.
Ruled, go ahead.
True.
In 2021, Texas Tech University Health Sciences Center strongly recommended that all staff, faculty, fellows, and residents who tested positive for COVID should stay off of the campus for a period of days before returning, true?
True.
Your institution, Texas Tech, required compliance with federal guidelines concerning continued operations on campus, including CDC guidance, true?
True.
Okay. CDC guidance in 2021 required, amongst other things, that persons who were symptomatic with COVID or sick stay home and not go to the hospital until CDC criteria for return were met, true?
I think the problem with that is persons. There were different policies depending on whether you were an employee or you were a patient seeking help.
Okay, Doctor, if you could reference page 348 of your deposition transcript, please.
Which one?
I think it's in the January 4th version. Page 348. Let me know when you're there. Are you there, doctor?
Almost.
Okay.
I'm there.
Okay, I'm referencing line 17. Question starts at line 17. It reads as follows. And that CDC guidance in 2021 required, amongst other things, that persons who are symptomatic with COVID or sick stay home and not go to the hospital until CDC criteria for return were met. True? And your answer at line 22 was correct. Did I read that correctly?
You read that correctly, but
Okay.
again, I may not have appreciated the nuance of the question
Okay.
at that time as I do now. Persons, there are different categories of persons and employees. There were different rules for employees versus patients who were seeking care at the hospital.
Okay. But that's not the answer you gave me at your sworn deposition, doctor.
I'm, am,
No, I think he can just, why don't you just tell us, doctor, why you answered the question at the deposition that way and why you're answering the question this way?
so, at the time, when I answered the question, I didn't appreciate the nuance of the word persons as I do now.
Okay, and what does that mean for all of us?
So there were different guidelines depending on whether you were an employee or whether you were a patient seeking care at the hospital. Both of those are persons.
And how would it impact what we need to know today?
I'm not sure why he's asking the question.
Okay, go ahead, Attorney Franconia.
Doctor, the only facility that you worked in 2021 was the clinic at Texas Tech and University Medical Center, true?
True?
That medical center specifically required reporting of symptoms or a temperature check before anyone would be allowed into the facility.
True?
You participated in the treatment of COVID patients in your hospital's ICU in 2021 who did not have visitors.
True?
That's because your facility had a policy in place which limited or restricted visitation in the hospital due to COVID, true?
True?
In caring for COVID patients in your hospital's ICU in 2021, it was necessary for you to communicate with family members or other individuals who were powers of attorney for one of your patients, true?
You're going to have to repeat the question.
In caring for COVID patients in your hospital's ICU in 2021, it was necessary for you to communicate with family members or other individuals who were in fact powers of attorneys for one of your patients.
Yes?
Okay. The means of communication that you would use to communicate with patient family members when those family members were not present in the hospital was generally a phone conversation that would be carried out in the room with the patient so that the patient and the advocate were both on the conversation.
True?
Okay. In such a situation, you would be in the room with the patient and a telephone, and the patient, family member, or advocate would be located remotely on the other side of the telephone line.
Actually, I was not in the room with the patient. Another person would be in the room with the patient holding a communication device. They would be able to see me. I would be sitting outside the room and it would be like a conference call. But our policy did not, because of my age, did not permit me to enter into COVID rooms.
Okay. Why did your institution's policy not permit you to enter into the COVID rooms?
They were concerned about my health.
They were concerned that your health might be compromised by entering into the room with an actively symptomatic COVID patient?
Yes.
Okay. So in such situations, you were able to communicate remotely with the family members of or the advocates of your patient, but you were in fact outside of the room talking on a communication device to someone in the room and then talking with a third person on the other side of a communication device for a conference call?
So I was able to communicate. Question of how well is another story.
Okay. But that is what you did in your personal experience at your institution during the COVID pandemic.
Correct. I would have the best conversation I could, given the rules.
Okay. In such a situation, you were able to accurately communicate with that patient advocate who was not present in the room with you, true?
It was less than optimal.
Okay. Doctor, if it was less than optimal, why did you do it that way?
Choice. It was either do it that way or not do it at all.
Okay. And that was the way it was at your facility throughout COVID.
Yes,
And this was the manner that you just described in which you conducted your own conferences with patient advocates for your patients.
yes,
You also had some other ways at your facility in 2020 and 2021 to communicate with family members or advocates who were not present in the room, including Zoom.
we didn't have Zoom capability at the hospital.
Okay. You did telemedicine visits by Zoom on a regular basis in 2021.
So, okay. From the clinic, I did Zoom telemedicine. From the hospital, I don't know what software they were using.
In the hospital, they used some sort of remote communication technology or platform. You just don't remember what it was. When you would be discussing or meeting with patients or patient family members from your clinic, you were able to do so remotely utilizing Zoom.
Correct.
Okay. When you would do these telemedicine visits by Zoom in 2021, sometimes those telemedicine visits were with patient advocates or a person who was the power of attorney rather than the patient, him or herself.
Correct.
Okay. In your experience, you were able to adequately and appropriately communicate with those family members or patient advocates via telemedicine in your practice in 2021. True?
Are we talking about the clinic?
Yes.
In the clinic, yes.
Okay. You believe that the care that you provided in 2021 to those patients met the standard of care despite the absence of a family member directly present in the room with you and the patient, true?
I did the best I could with given the circumstances. I think given the standard of care at the time, yes.
Okay. Why do you believe you complied with the standard of care given the circumstances at the time and the way that you communicated remotely with patients and patient advocates?
When you're given a choice to do something this way, or you can't do it at all, this way is the best you can do.
Okay. And you, being a good doctor, chose to do the best that you could do.
Yes,
The CDC was requiring your hospital to comply with certain regulations in 2021, for example, limitations on who could be in the hospital, true?
I'm sorry, you have to repeat the question.
Sure. The CDC was requiring your hospital to comply with certain regulations in 2021, for example, limitations on who could be in the hospital, true?
Yeah, I don't think it was the CDC. I think it was Medicare. If you didn't comply, you wouldn't get paid by Medicare.
Okay. If you could refer to page 355 of your deposition.
Which one?
Page 355, and that would be the January 4th edition. Let me know when you're there.
I'm on 355.
Okay, I'd like to reference a question starting on line 13. And that question reads as follows. The CDC was requiring the hospital, your hospital obviously, to comply with certain regulations. For example, limitations on who could be in the hospital. True? Your answer at that time was yes. Did I read that correctly?
You read that correctly, but my answer in the deposition was incorrect. The correct answer is it was Medicare or CMS that had the requirement.
Okay, so whether it was the CDC or Medicare, one of those entities was requiring your hospital to comply with certain regulations.
Yes,
Okay. Because your hospital was required to comply with those regulations, you believe it was not a violation of the standard of care for you to render medical treatment to patients in the absence of a patient advocate or family member in the room. True?
I don't think it ever came up that I had a patient on the COVID ward who required an advocate. I don't think that situation came up with me.
Okay, doctor, if you could refer to that same page of your deposition, it's once again 355. Okay, and this is going to start on line 18 with the question there. Are you there?
No,
Okay. Here's the question starting at line 18.
I'm not there yet.
Okay.
I'm there now.
Okay. Starting on line 18, the question reads as follows. And because the hospital, your hospital, was required to comply with those CDC regulations, it was not a violation of the standard of care for you to render treatment to those patients in the absence of a patient advocate or family member in the room. Your answer was yes. Did I read that correctly?
Yes, but the question, I don't think the situation where ever came up where I had a patient on the COVID ward who was not competent to make their own decisions and required an advocate. I don't think that situation ever came up.
Okay. Doctor, it was not a violation of the standard of care for the hospital to offer treatment to an ICU patient with COVID, despite the fact that there was no family member or advocate present in the room.
I don't think I gave an opinion on that question.
Okay.
Again, you're asking about my care. You're asking, did I violate the standard of care? Well, the situation didn't come up, so I didn't violate the standard of care. Every COVID patient I took care of was competent to communicate with me.
Okay. Doctor, if you could reference once again, page 355, starting on the last line. It's the same page starting at line 25. The question there begins with one line and then moves to page 356. And it was not a violation of the standard of care against the hospital or for the hospital to offer treatment to an ICU patient with COVID because or in light of the fact that there was no family member or advocate in the room.
Right. So again, you're distinguishing between ICU patients and patients. Not every patient was in the ICU. So for the ICU, you didn't have a choice. Either you rendered the care in the absence of an advocate, or you didn't accept the patient. Our ICU actually made exceptions for patients who required advocates, so cognitively impaired, et cetera. Exceptions were made for those patients to permit the advocates. So we never tried it your way.
And doctor, just for the purpose of completing the reading of that line, you kind of started before I had a chance to finish reading it. Your answer to that last question that I posed to you was correct in your deposition transcript, true? That would be on page 356, line 5.
Yeah. I said correct, but again, um, at our hospital, the situation you describe in the question didn't exist.
Okay.
So there were no violations of the standard of care. Situation didn't exist. If the patient required an advocate because they were incompetent, an advocate was permitted in the room.
Okay. Doctor, you believe your hospital's care of these patients in the ICU at your facility in 2021 met the standard of care?
Yes,
Okay. Hospitals cannot be held responsible for doing things that they were required to do by the CDC, true?
I'm going to object to that as that's a legal question.
Sustained. And the jury should just disregard that question. The issue of liability is going to be for you to decide.
Doctor, do you believe that hospitals cannot be held responsible for doing things that they were required to do by the CDC?
Same objection, Your Honor.
And I'm going to order that you disregard that question as well.
Your Honor, if I may request a sidebar, please.
Okay. Go ahead with your next question, Attorney Frankowiak.
Doctor, you would not be aware of any hospitals that did not have some sort of policy restricting visitation during the 2020 and 2021 as a result of COVID, true? It is not a surprise to you that St. Elizabeth Hospital also had such a policy in 2020 and 2021, true?
true.
Okay. Doctor, you do not fault St. Elizabeth Hospital for complying with its policy in 2021 or 2022 to restrict the visitation of visitors?
Objection, Your Honor, as to the use of fault. I think it goes to a legal question again.
Sustained.
Doctor, you've heard of a situation where a family member was asked to leave a hospital because that family member was interfering actively with the care provided to the patient, true?
I'm sorry, we talking about at my hospital?
You have heard of situations at your hospital where a family member was asked to leave a hospital because that family member was interfering actively with the care provided to the patient?
Yes,
Okay. For a period of time after Mr. Schara left the hospital on the morning of October 10th, there was a process set up by which the nursing staff and the doctors were able to communicate with Mr. and Mrs. Schara via either telephone or via iPad that day, true?
there was a process set up. It didn't always work.
Mr. Schara did in fact have multiple contacts, at least 3 different contacts with the nursing staff or the doctors on October 10th, 2021 for updates on Grace, true?
I don't know.
Okay. The next day after Mr. Schara was asked to leave the hospital, October 11th, Grace's sister Jessica was present with Grace that afternoon, true?
I don't recall the exact time she was able to get in.
Okay. There was no point in time in the record where Jessica did not have open and free access to communication with her father and mother via FaceTime or iPad while she was in the hospital room with her sister, true?
Well, again, I think they had a process in place, but whether it worked or not, I wouldn't know.
Okay. There is nothing you can point to in the record to indicate that Jessica was inhibited in any way whenever she needed to put her father in contact with the medical providers and she was unable to do so.
You know, there were times when Mr. Schara would call and want to speak to somebody, and that somebody wasn't available.
Okay. Doctor, if you could reference page 474 of your deposition, please. This would be the January 4th edition.
Which page?
474.
I got lucky and I got right to it.
Oh, perfect. The question starting at line 14 reads as follows. Okay, is there anything you can point to in the record to indicate that Jessica was inhibited in any way whenever she needed to put her father in contact with any of the providers, that she was unable to do so? Your answer was no. I think she was able to get contact when she needed it. Did I read that correctly?
Objection, Your Honor. That is not the same question.
It's not the question you asked me.
It's the same question, I believe, Your Honor.
Okay, so what we're gonna do is, and we talked about this at lunch, we're
Sure.
just gonna have the court reporter read back the question that you had asked of this witness, and then we're going to have the court reporter read back what you just said, the deposition transcript. Let's see if they're the same.
Perfect. The question starting at line 14 reads as follows.
No, so
Okay, there is nothing you can point to in the record to indicate that Jessica was inhibited whenever she needed to put her father in contact with the medical providers and she was unable to do so. Perfect. Question starting at line 14 reads as follows. Okay, is there anything you can point to in the record to indicate that Jessica was inhibited in any way whenever she needed to put her father in contact with any of the providers that she was unable to do so?
you can go ahead and answer.
Okay. I believe that there's information that was not available to me at the time of this deposition that has become available to me since, where Jessica was trying to arranged some kind of communication, but it just resulted in a message being passed to people and no actual communication.
Okay. You believe Jessica played a valuable role by being in the room with Grace?
Yes,
Okay. If Scott Schara had wanted to remove his daughter Grace from the hospital at any point from the date when she presented until the date when she passed away, he had the ability to do so?
Objection, Your Honor. Foundation and calls for speculation.
well, I'm not sure what it would have happened if he tried.
Okay. But the question, sir, was whether or not he had the ability to do so according to the documents that you have read.
And since I don't know what would have happened if he tried, I can't answer the question.
Okay. Doctor, you believe that had Scott Schara removed Grace from the hospital prior to her passing, that she would have survived?
Depends when.
Okay. Dr. Precedex is a medication that is used for the treatment of delirium, true?
Yes,
As a consulting pulmonologist, you've had patients where there was a medical need for some kind of sedation, true?
yes,
In such a case, Precedex would be frequently the first drug you would go to.
not me. It would be the first choice for other providers.
Precedex would typically be the initial drug chosen to sedate someone who was either on non-invasive ventilation or on a ventilator.
Objection, vague. Foundation.
Yes, some providers would use it as their first drug to treat those situations, but I wouldn't.
Okay. Non-invasive ventilation would include things like BiPAP, like what Grace had in this case.
Yes,
Okay. The actual use of Precedex does not concern any particular standard or does not cause any particular standard of care concerns for you.
I'm sorry, can you repeat that?
Certainly. The actual use of Precedex does not cause any particular standard of care concerns for you.
Well, the fact that Precedex is used by itself would not be a violation of the standard of care. It would all depend on how it was used.
Okay. As a consulting pulmonologist, you do not use Precedex personally, true?
True.
During the course of your practice, you have never had an informed consent conversation regarding the administration of Precedex with anybody, true?
True.
You've never been in a position where you had to monitor or rectify a drop in blood pressure as a side effect of Precedex, true?
That's an advantage of not using the drug.
Okay. When it comes to the administration of Precedex, the dosage should be individualized and titrated to a particular desired clinical effect, true?
True.
In the case of Grace Schara, given her overall clinical picture, it was a proper desired clinical effect to try to increase her oxygen saturation.
It was appropriate to try to do so,
Okay.
but they were not able to do so by the use of Precedex.
It was a proper desired clinical effect to make Grace as comfortable as possible with the oxygen delivery system being used for her, true?
It depends what you mean by as comfortable as possible. If what you mean by as comfortable as possible is comatose, I would say no.
Okay. Doctor, if you could reference page 244 of your transcript, please, that would be the December 13th version. Let me know when you're there.
Which page?
Page 244. Line 11, doctor. Starting with line 10, the question begins. With regards to, I'll rephrase it, Was it a proper desired clinical effect to make her as comfortable as possible with the oxygen delivery system being used for her? Your answer was yes. Did I read that correctly?
You did.
Okay. It was a proper desired clinical effect to at all times make Grace comfortable with being in positions that might assist her breathing. True?
Again, so at the time I did this deposition, I did not have access to all of the information that I have access to now. And it has come to my attention since the time of this deposition, a number of things. One, there's no evidence in the medical record that there was an actual target for the titration of Precedex. So these questions, it's hard to say what was meant because they don't have a target. And if their goal was to make her comatose, no, that would not be appropriate. If their goal was to make her calm, a RAS of 0, well, that would be appropriate. If their goal was, say, to make her -1, which would be drowsy, well, I can see situations where that would be appropriate too. But there's nothing in the medical record that suggests they had any target.
Okay. Your review of the medical record leaves you with the impression that there was no target that the providers and the nurses were aiming for in terms of the RAS scale?
Correct.
Okay. Doctor, when you gave this deposition on December 13th of 2024, you had already written your initial report in this case?
Yes.
And you just told me that there was information that you didn't have at the time you formulated that report?
So one, the medical record is pretty big. The initial version I got was 1,600 pages. It's easy to miss things. The other thing is we have gotten the medical record in installments. We never have received the entire medical record at one time. In fact, the final installment of the medical record just came a few weeks ago. So there is stuff that we receive later that impacts how I would answer these questions.
And doctor, I think you said that aiming at a RAS score of -1 would in fact be an appropriate aiming point, true?
It might be.
Okay. If a patient experiences difficulty breathing, that patient may become agitated as a result of that, true?
True.
Edema in the lungs and oxygen hunger is one potential cause of agitation in an ICU patient, true? There were COVID patients who received care in the ICU at your hospital in 2021 who were treated with anti-anxiety or sedative medications, true?
True.
And the reason for the use of anti-anxiety or sedative medications for ICU patients having COVID would be to get on top of the patient's agitation.
True.
Okay. You have prescribed Lorazepam in the past?
Yes.
And Lorazepam is an anti-anxiety agent?
Yes.
There are situations where a patient's agitation is causing problems in an ICU setting.
Yes.
Lorazepam is a medication that's usually chosen as a one-time drug as opposed to a repeated or continued drug.
Depends on the circumstances. Lorazepam is still the favorite drug for the treatment of delirium tremens.
Okay. Lorazepam might be your best choice if you've tried other things and they have failed to get control of a patient's agitation, true?
True.
If no other method of dealing with agitation is having the desired clinical effect, then Lorazepam would be a reasonable therapeutic modality to try to get on top of that patient's agitation, true?
It might be, it depends on the circumstances.
Okay. It's important to get on top of agitation for a COVID patient in the ICU, true?
True.
When you're dealing with acute respiratory distress syndrome, agitation is going to increase oxygen consumption, which will lower oxygen saturation, thus making one of your primary metrics worse.
True.
Agitation might also cause the patient to pull out lines or tubes that might be deemed necessary for that patient's treatment.
True.
Physicians do not generally administer medications in the ICU. It's generally nurses who do that. True?
Depends on the medicine.
Okay. Sometimes there are indications where an individual is progressing to a point that would be considered an emergency, and a physician might need to step in to administer a medication in that emergent situation.
True.
You have never administered Lorazepam in an ICU setting personally?
I have.
You have prescribed the medication morphine for a patient in an ICU setting, true?
So you're describing a situation in an ICU. So this is not going to be a written prescription. This would be an in-hospital prescription. True.
And you have personally administered morphine yourself to an ICU patient, true?
True.
Okay. A patient's inability to maintain oxygen saturation above 90% is a significant finding, true?
True.
Okay. As a pulmonologist, you would like the oxygen saturation to be 90% or better. And when you can't achieve that, this becomes a red flag. Okay. The usual limits of normal respiratory rate are given as 12 to 20 breaths per minute, true?
True.
Okay. Based upon your training and experience, a normal oxygen saturation would be 95% or higher, true?
Repeat that one.
Based upon your training and experience, a normal oxygenation or oxygen saturation would be 95% or higher, true?
It would depend on what altitude you're at.
Okay, at sea level.
Yes.
As a pulmonologist, a respiratory rate of 30 breaths per minute or higher would be of concern, as would a respiratory rate of less than 6.
True.
Okay. You would have concerns that there would be an emergency condition if a patient's respiratory rate was above 50.
True.
A respiratory rate of 50 breaths per minute is very abnormal, true?
True.
As a pulmonologist, the lower a patient's oxygenation saturation is, the more concern you would have, true?
I'm the more compared to what?
An SpO2 reading in the 50s would be concerning to you because this would be a sign of a real problem, true?
True.
An SpO2 in the 50s would cause concern about severe hypoxemia, true?
True.
In your own experience treating COVID patients in the ICU, you've never had patients that exhibited SpO2 in the 50s, true?
Well, that's not true. I've had patients who've had SpO2 in the 50s. You don't want it to stay that way very long.
Doctor, if you could reference page 496, which would be the January 4th version of your deposition.
What page?
Page 496.
Okay.
Okay. Starting at line 2, there's a question that starts as follows. Your own experience treating patients, did you, or treating COVID patients in the ICU, did you have patients that exhibited SpO2 in the 50s? Your answer was no. Did I read that correctly?
You did.
Okay. An SpO2 reading in the 50s is not desirable, true?
That is true.
If a patient is exhibiting a respiratory rate above 50 while at the same time exhibiting an SpO2 reading below 60, that is a concern to you as a pulmonologist, true?
True.
Such a situation, the concern would be that you've got significant hypoxemia despite a high respiratory rate. So the main concern would be that respirations or the breathing is ineffective, true?
True.
In this circumstance, you are probably dealing with a tidal volume that's close to dead space or even below dead space, true?
True.
Okay. Doctor, when you first talked to Mr. Schara and his attorneys, the issue of medications was brought up to you. And one of the hypotheses that was floated to you by Mr. Schara was that there was an antagonism toward Grace by hospital staff because she was unvaccinated. And that was an antagonism, or there was an antagonism toward Mr. Schara himself for a number of reasons. And that the hospital basically tried to harm Grace with those drugs.
Objection, Your Honor, form and foundation.
Okay,
On form.
okay. Doctor, you do not believe, based upon your review of the materials you've looked in this case, that any of the doctors or personnel who are prescribing or administering any medications were attempting to harm Grace intentionally?
True.
That's all I have. Thank you, doctor.
All right, Attorney Guzzi.
Thank you, Judge. I think we actually have an operating mic today. So hopefully that will help things a little bit.
Thank you.
Good afternoon, Dr. Burdine. How are you? Getting a little tired?
I'm alive.
Still buying green bananas, right?
Better to be above ground than below.
Fair point. Hoping that we can maybe start off with a few simple things we can agree on. We can agree that your role in this case as an expert is not to be an advocate. Is that correct?
Correct. My role is to inform the jury about complicated technical questions.
And as far as your role is concerned in doing that, your role is to be fair and objective.
True.
And we can agree that the opinions you gave today must have scientific validity to them.
True.
They need to be.
True.
And this may seem obvious, Dr. Burdine, but we can agree that it's not your role to create facts in this case.
What you mean by create facts?
I want to ask you a couple questions, Doctor, about some of the topics that were covered today. One of them had to do with alarms, and then another one had to do with masks and masks falling off. Do you recall those two areas? Yes. Okay. So with the alarms, you're familiar with BiPAP machines?
Yes.
They have alarms on them?
Some of them do.
For the machines that have alarms on, is that in part to alert nursing staff that a mask may have fallen off?
The BiPAP machines the hospitals use have multiple alarms, but one of them can be related to leak.
Leak. So in other words, if
Yeah.
let me just ask you a question, Doctor.
Sure, but the leak, the machine can't tell whether the leak's coming from the mask or somewhere else. It just knows there's a leak.
The pressure's not where it needs to be.
The
Skill's not right.
the relationship between pressure and flow in the system is wrong.
And in order for a BiPAP machine to work to its full effect, the mask has to be sealed to the face, right?
Correct.
And one of the alarms on the BiPAP alarm or BiPAP machine is also to indicate seal, essentially, right?
Well, seal is the opposite of leak. So if an alarm indicates leak, its opposite would indicate seal.
And if an individual is on a BiPAP machine and they're dependent on that BiPAP machine to breathe, it's important to know for the nursing staff, if that mask falls off or is not sealing properly. Wouldn't you agree?
True.
And that's the purpose of alarms.
Well, if the nurse is in the room and there's a leak at the mask, it's obvious, you can hear it.
I appreciate your answer, Doctor, and I know based on our conversation, you're trying to be helpful here today, but my question was, in terms of the alarm on the BiPAP machine, it's important for the nurse to know via that alarm that there's an issue with the mask.
Yes,
And so if those alarms are turned off on a patient who is dependent on that BiPAP machine, that can create a dangerous situation. True?
it could, but not necessarily.
Wanted to ask you a couple questions about DNR status. There was discussion about DNR status and a feeding tube. Do you recall that testimony?
Yes,
And I believe you said that that they should have held off on the feeding tube.
they should have thought about it.
All right. You understand that a DNR designation does not mean that treatment for the underlying condition stops.
That would be the correct interpretation.
And that would include providing nutrition to the patient.
It would include a lot of other things too.
Understood. You understood from reviewing the records that Grace was malnourished, right?
They called Grace malnourished. I don't know that they had objective evidence for it, but Grace was labeled as malnourished. I can appreciate the concerns they had about the feeding tube, but there's good timing and bad timing.
So your answer is yes, the records reflect that she was malnourished.
Record reflects that she was labeled as malnourished.
Doctor, you cited to an article. in your
I cited a
testimony.
lot of articles.
Let me finish my question, sir, please. Maybe I'll talk a little faster for you. Today, you referred to an article from the Journal of American Medicine. I'm sorry, JAMA. What's JAMA again? It's been a long week.
Journal of the American Medical Association.
Thank you. And that had to do with outcomes and mortality among adults hospitalized with COVID-19
In ICUs.
in ICUs. And that article came out in March of 2021. Do I have that right?
That's true.
And I may be missing it, but I thought the actual submission date was January of 2021.
The article was not cited to clear up something that happened during the course of this case. The article was cited to refute a claim by one of your experts.
I appreciate again, Doctor, that you're trying to be helpful, but my question to you is the report actually was, I believe, submitted in January of 2021.
The report, what report?
Sorry, the article. Submitted for publication?
Let's see.
Well, Doctor, the bottom line is it was published in March of 2021.
Okay.
We'll go with that.
Yeah, published March 5, 2021.
In this article is looking at data that was gathered between March of 2020 and August of 2020. Is that right?
Right.
So we're in a time frame that is measuring outcomes a full year before Grace was hospitalized.
So
I'm just asking the question.
Yes,
The authors to this article noted some limitations, did they not?
probably. They have a discussion of limitations. Yes,
And they raised concerns about, first of all, they note it's a retrospective study, right?
yes,
And they had concerns about misclassification and accuracy of coding and missing data.
yes,
Some of that missing data, doctor, would include, for example, well, let me back up here. Doctor, there's nothing in this study that tells us, for example, when the hospital admission occurred in relation to when symptoms started. True?
again, I don't see the point.
You may. not-
Okay, all right, yeah, you're right.
And this does not give us any information as to admission date relative to when the individual tested positive for COVID.
True,
And in a lot of cases, doctor, once you test positive for COVID or symptomatic, the sooner you get medical treatment, the better your outcome. True?
well, it depends. A lot of people don't get medical treatment at all and they do fine.
But as a general rule, with a medical condition, doctor, the sooner you get medical treatment, the better, the more likely it is that you are to achieve a better outcome.
Well, what do you mean by in general? So more likely than not, patients who don't get any treatment at all do fine.
Doctor, in terms of the general medical conditions, serious medical conditions that require hospitalization, the sooner you get medical treatment, the better the outcome.
Again, it depends on the situation.
So you're not going to give me this one, are you, doctor?
Well, you're going to have to be more specific.
All right, doctor. Doctor, we can agree that, back up, doctor, your opinion is that in general, let me start over. Your opinion is that all drugs administered in a hospital require an informed consent discussion.
When the patients or their advocate makes it clear that they want that information, yes,
Can we agree that there are exceptions for emergent circumstances? Would you agree with me, doctor, that in terms of determining whether a situation or a condition of a patient is emergent is it's the physician treating that patient that's in the best position to determine whether it's an emergent condition? I'm not sure whether you talked about it in your direct examination, but we can agree that one of the components of late COVID can be ARDS.
it can be one of the manifestations of early COVID.
Fair point. And just so that we're all using the same terminology, ARDS is acute respiratory distress syndrome.
Correct.
ARDS can cause hypotension, can't it, doctor?
Yes,
And we can agree that the more severe ARDS is, the more likely there's hypotension.
correct.
Impaired oxygenation can cause hypotension as well. Agitation can cause increased oxygen consumption and lower SATs.
Yes.
Can we agree that Dr. Shokar was not involved in the decision to ask Mr. Schara to leave the hospital on October 10th?
Yes,
You would agree that Dr. Shokar did not place the order for Precedex?
yes,
You would agree that Dr. Shokar did not set the titration parameters for Precedex.
Yes,
We agree that Grace was not under the care of Dr. Shokar on October 7th, 2021 and October 8th, 2021, when Grace experienced what you have labeled as overdose.
yes,
Can we agree that the Lorazepam administered to Grace in connection with the insertion of the NG tube was not ordered by Dr. Shokar?
I don't recall who ordered that drug.
And we can agree that the second dose at 1746 of Lorazepam was based on a PRN order by Dr. David Beck and not Dr. Shokar.
I'd have to refer to the medication sheet.
Doctor, you've discussed metabolic acidosis. So I want to cover that a little bit, and then we'll be done. You testified that a base excess can indicate a chronic, a metabolic acidosis.
So chronic has nothing to do with it.
That was my slip. I'm just asking him if that was my fault. Let me ask a better question. Can we agree that a negative base excess can indicate a metabolic acidosis?
So not can, it does.
A negative base excess can also be an indication of chronic respiratory alkalosis. True? No. Can we agree that respiratory
So I just want to explain, because you've gotten some very bad information. A respiratory alkalosis would have a base excess of 0.
in terms of ARDS, doctor, respiratory alkalosis can occur with ARDS?
Yes,
Now, my understanding is that you received this case sometime in March of 2023.
I don't remember exactly when. It's been a long time.
So we can agree that's been a long time that you've had this.
Long time.
And you've had medical records to review a long time. And your theory of metabolic acidosis in this case is pretty central to your overall opinion on Grace's cause of death.
I don't know if central is the right word. It's certainly part of my hypothesis.
It's a very important opinion in this case in terms of the rest of your opinions.
The presence of metabolic acidosis is an important part of my hypothesis.
You prepared 3 reports in this case, did you not? Yes. And I think the first one came out in May of 2024 or so. Does that sound right as to when you authored it?
I'd have to see the dates on the reports.
Presumably you read those the medical records you were provided, what, once, twice, 3, 4 times before you produced that report?
The entire medical record 4 times? No.
How many?
I had gone through much of the medical record, looking for specific things. So there are hundreds and hundreds and hundreds of pages about these nursing sheets about it's really hard to even find out what's changed on the page. You have, wait a second, you asked me a question, let me answer it. So I did not spend a lot of time on those pages. I did spend a lot of time reviewing medication records, laboratory values, imaging, looking at the progress notes. So those aspects of the medical record, I did spend a lot of time on.
So you would have reviewed those aspects of the medical record several times before you wrote your first report?
Necessarily several. I may have reviewed them once. I take notes.
And then you produced the second report in about December of 2024. Is that right?
Again, I'd have to look at the date, but I don't see anything wrong with that date.
Would it be fair for me to assume that between the time you wrote your first report and your second report, you reviewed Grace's medical records again? At least the ones that you thought you deemed to be pertinent.
Took a second look at some things, yes.
In both, in terms of your first and second report, doctor, terms metabolic acidosis never show up in those reports. True?
I'd have to look through the reports.
Do you have the reports in front of you?
Yeah, if you want, it's like a 30-page report. You want to have me read the whole thing?
I don't want you to read it, but I would like an answer to my question. If the court's willing to give us a short break for you to review those reports, that's fine with me.
You have other questions?
Yeah, I can't until this is done.
What we'll do is, we'll take a break. We have one coming up anyway, probably in 15 minutes. And what we'll do is try to take a 10 or 15-minute break, unless you need more time than that. And if you do, let the bailiff know right away. The plan would be after Attorney Guzzi's done asking questions, it'll be taken back. The plaintiff gets to ask redirect, and then the jurors will be able to ask questions, and then we'll be finished for the week. So I don't know exactly how long that will be, but that's the plan. You can't discuss this case with anyone, including each other. You can take your notebooks with you and then just bring those back in. The jury is excused. All right, you may be seated. This is a hearing outside the presence of the jury. Dr. Burdine, you can step down, but if you want to review those reports before you come back in, and
Oh, I'm
I mean,
sorry.
you can do it right there if you want, or
If I can do it right here, I'll do
Perfect.
it right here.
perfect with me. So he'll do,
Just so you know, I'm like within 2 minutes of being done. So.
okay, and then we'll just go back to you. How long do you think you're going to be?
10 to 15 minutes.
We had one sidebar during the session that we just finished. I think Attorney Guzzi, you had, or maybe it was Attorney Frankowiak had asked for it, but
I've been pretty quiet.
okay. So there was a question regarding whether hospitals can or cannot be liable for filing a CDC policy. I think that was what staged the sidebar, right?
Yes, I believe it was testimony that he had given me to that effect. That's
Okay, and then during the sidebar, you had asked me to take a look at 80407 sub 1 sub C 2. And I did that. But so I'll just kind of say what I think we said during the sidebar, and then I'll give you a summary of what I did, and then we can talk about it. During the sidebar, Attorney Frankowiak and Attorney Guzzi, you both thought that it was appropriate to be able to use an expert's deposition testimony in any respect, regardless of the rules of evidence, because it was something that that person had testified to at a deposition, and you cited the statute that I just indicated. That just doesn't make sense to me. And so during the sidebar, I said, well, what happens if the expert would have testified that he has 10 dogs? And like, we're not going to bring that in. It has no relevance or anything to do with this case. During the sidebar, I also indicated that I was concerned about the CDC has a policy, and why would their policy, if it talks about liability, would be thrown in front of this jury? It's confusing, it's misleading. You know, in terms of liability, legal liability, or liability to the CDC, or liability that they don't get their funds, or anything else. And then I think plaintiff counsel, you chimed in and said, I think what you said was that there was a difference between CDC and CMS. Is that?
Yeah, yes, Your Honor.
Okay,
It was
and-
Medicaid versus CDC.
And I understood the argument kind of twofold. First of all, it's an improper legal question to an expert. Mr. Mendenhall, you were pretty aggressive in that. And then, you know, the concern that we're going to start asking experts the ultimate question that the jurors are going to be asked. So in any event, that was our sidebar. And I looked at the statute in 80407 sub 1. Says at the trial or upon the hearing of a motion or an interlocutory proceeding, any part or all of a deposition, so far as admissible under the rules of evidence applied as though the witness were then present and testifying, may be used. And it was, I know that's not the statute you cited, but that was a reminder to me that, yeah, deposition testimony can be used, but we're going to follow the rules of evidence. And then you move forward to the site that you had, 80407 sub 1, which was the same provision that I just read, then go down to C2, and it says the deposition of a medical expert may be used by any party for any purpose without regard to the limitations otherwise imposed by this paragraph. And I would think that your suggestion is that the rules of evidence don't apply to a discovery deposition of an expert, medical expert, even if those questions relate to ultimate questions of law that the jury's going to have to decide.
No, I was just reading the
Okay.
word said that I could use it for any purpose, and ultimately that was just an opinion that he gave. He gave me that opinion in his deposition that
Well,
I can't hold, or you can't hold a hospital responsible for complying with a government regulation or CDC or whatever, however it was turned. I was just going by what he told me at his deposition, and
since at this trial.
of that is because there has been testimony, and there will be testimony, that one of the reasons Mr. Schara was asked to leave was because he was exhibiting COVID symptoms, and there were regulations that required people to not to be in the hospital during COVID, when they had COVID.
I allowed you to ask those questions. And I will continue to allow, because that's not an ultimate legal question that the jury's, everything you just said and answer to me had nothing to do with liability.
This is basically establishing that this doctor does not even believe that my hospital should be held responsible, even though that's what he's saying. It's an impeachment question.
I doubt that's what he said. I mean, as a matter of fact, I think his testimony in this case has been very clear that your clients violated various standards of care. And I think he used terms such as insane, non-defensible, you know, all those terms that we heard him testify to. But again, the question about liability of a hospital to CDC has nothing to do with this case. So I want to just frame the question. Are you suggesting that with the statute that you provided to me, that the deposition of any medical expert can be used at any time in front of a jury, including legal questions or questions that aren't relevant or things bearing upon the ultimate questions that we're going to ask the jury?
No, I'm just
Okay.
referencing that for the language that says a deposition of medical expert can be used by any party for any purpose. I believed the question was relevant to what he is saying my client did. When he's saying my client did it, he's saying they violated the standard of care. When he takes the same situation with a generic hospital, he's saying I can't hold them responsible. I was trying to bring
I
that
don't think
out.
that's what he said.
That's what the way I interpreted that testimony.
Okay, so I'm glad that you weren't saying that with the medical experts, because I was going to ask, and I would do additional research. So my ruling then is what I said during the sidebar, that I just think it's misleading. It's a legal question. I'm not sure what he said during his deposition, and it's a discovery deposition, so he should answer it and give you his thoughts. It's not relevant to any of the issues in this case, and ultimately the jurors are going to be asked about liability, and I think it'd be misleading for us to provide them whether or not CDC or CMS or whoever else has opinions about it. I don't think matter. You'll get into the question that they were following policies, which I've allowed. But when you start throwing in the issue of liability, I just didn't think it was appropriate. Anything you want to add on that sidebar?
Your Honor, I actually do have something to add.
Okay, Mr. Middle.
I'm very concerned about the misrepresentation of what the law is here with the CDC. The CDC has no enforcement power, no policy-making power over these hospitals, and they know it. It is CMS that controls them. CDC can merely issue guidelines, health guidelines. That's it. You are not responsive. And I apologize for pointing to my friend over here, but he knows this. He's got CDC throughout the depositions and here today, and it's false. They're not a regulator, Your Honor. They're merely a recommender.
I don't know if that's true or not true. To
Well-
be honest with you, to be frank, I don't know the difference between the two. But the bottom line is, as it relates to this trial, if the hospital was following guidelines from fill in the abbreviations, that can be testified to. But it's not going to be testified to that you can then not be liable, because I think that's just starts confusing legal issues. So if your clients are going to say, we're just following what the CDC said, or CMS, I'm okay with that. And I think that's fair. Okay, so I'm not trying to say don't do that, but we're not going to talk about, because I was following the CDC policy, I can't be found liable in a court of law. I don't think that's appropriate.
No, I know. For completeness of the record, the reason that came up is because this witness did tell me at deposition that his own hospital followed these policies, and that's one of the reasons he believed that he was able to meet the standard of care, because hey, even though I didn't like it, I had to follow these policies.
He testified to that. That all got in, I thought, this
Well,
afternoon.
I know, but that was the basis for what these things were. That
Understood, but that's different than that question on the hospital can't be liable because they're following a CDC policy. So I'm going to allow both sides to inquire in. And you can talk about CDC or CMS. You've already done that. You can ask experts, but we're not going to get into they're immune from liability because they're just following policy or any suggestion on it. Let's take an afternoon break. How long are you going to need, doctor, to get through that?
I'm through it.
Okay, so if we were to say 10 minutes, is that enough time for everybody? Okay, so we'll start at 10 after. We're adjourned.
He's coming down. All right, everyone can be seated. All right.
Welcome back, members of the jury. This will be, hopefully be the last stint before you take off for the weekend. And just so I don't forget at the end, so during the weekend, you have more time. So the rules are going to be the same, and sometimes that's complicated. So, if you go out to dinner tonight, or you do what you normally do on Friday nights or Saturdays, and you're spending more time with families and friends, the rule is no contact whatsoever about this case, except you currently are serving on a jury. It's a civil case. And you have to be back next week, if you're talking to your employer or whatever it is. But, historically, jurors do really good. And then every once in a while, we get a situation where we just have, that's been violated, and it just creates problems. So I'm going to try to encourage you just to continue to follow those rules. And then obviously no independent research or no looking into things. And I just use myself as an example. Can't look into Judge McGinnis and research me or any of the witnesses or parties or any of the issues associated with this case at all. And I appreciate your attention this week. I think you guys are doing a great job, from what I'm able to observe. And so thanks for all of your efforts. We're going to turn it back over to Attorney Guzzi. And then there'll be some redirect, and then your questions, and then we'll be done for the week. Attorney Guzzi.
Do we have a working mic? We do, right? All right, just want to make sure every time. So Doctor, I think we left off talking about your first two reports. Have you had an opportunity to review those two reports?
Yes.
The words metabolic acidosis show up in those reports anywhere?
The words what?
Metabolic acidosis.
Oh, I do not mention metabolic acidosis in either of the first two reports.
In fact, the first time you reference or use the phrase metabolic acidosis in a report is a report that you authored earlier this year, January or February. True?
The rebuttal report.
Yep. And so that's the first time after having Grace's medical records for almost 2 years that you put into a report that there was metabolic acidosis. Is that right?
That is correct.
All right. Let's talk about that report real briefly. And I want to refer you to about the page where you're discussing metabolic acidosis. pH level that you calculate. I think we're on page 4.
Okay. I'm on page 4.
So you calculated a pH of 7.30. Is that right?
I calculate. Yeah. So we don't have a blood gas on 1013. We have venous blood chemistries, and so I calculated what the pH would have been based on the previous blood gases, and then extrapolating to the bicarbonate level or total CO2 level on 1013.
I just want to make sure I'm clear, and maybe I'm not, because I'm not a pulmonologist. I don't know how these calculations are made, but in order to calculate a pH of 7.30, you would have used what, the bicarb of 19?
So I start with the initial. Actually, I use the Davenport diagram, which Attorney Fleiterer decided would not be a good idea for me to introduce to the jury. I use a Davenport diagram, starting with the blood gas values of 1012, and then going on the basis of what we knew about the total CO2 or bicarbonate value on 1013. So the two axes on a Davenport diagram.
Doctor, if I may, I want to see if we can shorten this up a little bit for the jury. In order to make that calculation, you would have used a PCO2 of 40?
In order to make the calculation, I had to have a starting point. Starting point was based on a blood gas on the 12th. The two axes on a Davenport diagram are bicarbonate and pH. So I have a starting point, and then if the only change is metabolic acidosis, and I go from the bicarbonate level of the blood gas on the 12th to the blood bicarbonate level on the 13th, then I get a pH that would correspond to.
All right, Dr.
So it's not an equation, it's a graphical analysis.
Thank you for the clarification, Doctor. I appreciate that. That's all I have.
Redirect Attorney Flater.
Thanks, Your Honor. Dr. Perdine, you just said that I did not want to include the Davenport diagram in this presentation. Could you tell the jury what I said about the Davenport diagram?
You said it would be too difficult to explain to the jury who didn't have the necessary science courses.
And in fact, you and I worked together and you tried to explain that diagram to me numerous times.
Convinced me that you were correct.
Yeah. Okay, Doctor, I want to get into, I want to start with some of the things that counsel for the hospital said here. The first one was, you were asked the question, I think the question was, nurses do not make diagnoses. True. And you said something to the effect of, well, they can make diagnoses. Is that right? Is that fair?
Correct.
And then attorney or counsel for the hospital gave you your deposition and kind of made it seem like you weren't consistent with that deposition. And so I want to put, this is page 307 of volume 2 of your deposition. This would be your second one. And when counsel for the hospital was, can we go down to 307,
If
please?
you want to stand and get closer to one of those screens to look at it, you can too.
Yeah, can we zoom in there on kind of, let's go with line 9. We just need line 9.
Right.
So it says, medical diagnoses are made by physicians. True. And this was your answer. Well, medical diagnoses are made by all sorts of people. The credibility of the diagnoses will depend on the person making it. But you can ask somebody on the corner of the street and they may give you a medical diagnosis. So, Dr. Burdine, if we go down the page here, this is where counsel for the hospital started. He says, the question is, would you agree with me that nurses are not qualified to render medical diagnoses, whether they try to do so or, next page.
Right, and then I said, I didn't say qualified, I said they do it.
Right, right. I want to go to page 347. Counsel for the hospital made a few statements about visitation policies, and I think you testified something to the effect of, at your hospital, there was a visitation policy that prohibited visitors during COVID. Is that fair, doctor?
That is fair.
Okay, and forgot my glasses today. I don't know.
And you can walk up to
Yeah,
the
I'll
screen
go
if you
up
want
too.
to.
Okay, got it. Okay, so, yeah, right there at the bottom, starting on line 24, it says, it's talking about the visitor policy there, I should say line 19. Doctor, we talked a little bit at your first deposition about whether or not your own hospital facility had a visitor policy for COVID. Do you recall talking about that a little bit? You answered, I'm not sure, but I know what our policy was. And then next question, okay, what was the policy at Texas Tech in 2021 for visitors to the hospital on the ICU? And what counsel for the hospital brought out on testimony was there were no visitors permitted, but what he left out of the testimony was exceptions were made for cognitively impaired patients. Doctor, was that the case?
Yes.
Okay.
Can I elaborate?
Sure.
So our hospital has a contract with an institution called the State School. The State School houses institutionalized patients who have various level of cognitive impairment to various ages. So they have all the way from infants to adults. And so these patients come to the hospital with a caretaker from the facility that is their guardian. And it was our policy in the ICU that if we had state school patients, that the guardians were permitted in the rooms with the patients.
I want to clear one other thing up. Counsel for the hospital brought out some testimony that you were part of a group of people who disagreed with certain hospital or medical policies around COVID. Do you remember that?
Yes.
And he said that I think one of the primary positions of this group was it was against the substantial isolation of families from patients in the hospital. And I just want to confirm, Dr. Burdine, are you against isolating families from patients?
Yes.
Okay. Thank you. Next, there was some discussion about when you reviewed the deposition of Nurse Holly McGinnis. Do you remember that?
Correct.
And I think you testified that you did actually later review the deposition. You couldn't open it for some reason or.
Yeah, you sent me an MP4 file instead of a PDF.
I said I'm not a tech guy. Following your review of that deposition, did any of your opinions change?
Yes.
Okay, how did they change?
The testimony of Nurse McGinnis affirmed or confirmed some of the observations made by Jessica. And prior to seeing Nurse McGinnis's affirmation of those opinions, there was some doubt as to whether Jessica had the technical skill to make those observations, but Nurse McGinnis made the same observations.
Understood. You got some questions from counsel for the hospital that you're not a pathologist, you're not a radiologist, you're not a toxicologist, you're not an infectious disease doctor. Do you remember those questions?
Yes.
Okay, first of all, we'll just start from the top. What is a pathologist?
Well, William Silent was my surgical teacher, a very famous surgeon, and he called pathologists dead tissue doctors. That's probably unfair, but pathologists review specimens, so biopsies. If surgical specimens are obtained at surgery, they review these. And they're doing a very important job. It used to be they were heavily involved with autopsies, but autopsies aren't done so much anymore. So that's become a lesser role. But just to give the jury an example, if somebody has breast cancer and they have a resection, a mastectomy for the breast cancer, the procedure may start out as just a needle biopsy to confirm the diagnosis, and they do a touch prep at the bedside and look at it. And based on their analysis under the microscope of the cells, it's confirmed whether they have cancer or not. And if they confirm cancer, then the patient has a mastectomy. And if they don't have cancer, then they avoid a major operation. So the pathologists play very important roles in those areas.
Dr. Burdine, do you need to be a pathologist to figure out what happened in this case?
No,
Why not?
well, there was no autopsy, so you can throw that out. Really, biopsy of tissue had essentially no role. So at most, there would be, say, sputum examination or something like that, but that really wouldn't tell you much. So we don't really have a role of a pathologist in determining the diagnosis, and the diagnosis is going to be made on clinical and radiographic grounds.
Okay, just briefly, what's a radiologist?
Well, again, William Silen called the radiologists the shadow doctors, and I think that's also a bit unfair. Radiologists review and interpret imaging. So they review plain radiographs, including chest x-rays. They review CT scans. They review MRIs, nuclear medicine studies. So they review all sorts of imaging.
Do you need to be a radiologist to figure out what happened in this case?
No, objection, foundation.
Overruled. Go ahead.
No.
Okay, why not?
Well, so I've previously stated in deposition to clarify, the question came up about whether a radiologist was more qualified to interpret Grace Schara's chest films or not than myself. And I said I was more qualified. And an explanation was asked, and I cheat. So the radiologist has the image in front of them and maybe a 10-word reason for the film, and that's all they have. But I have all the clinical records. I have the clinical information. I have the strategy we're doing. I know why the film was ordered. I know what we're looking for. And so I have insights that they don't have. And it makes it a lot easier for me to see what's important because I don't have to worry. So I'm looking at a chest x-ray. They can't miss if there's a fractured rib, but I can because I'm looking to see if the ARDS has gotten worse. And I know the patient doesn't have chest pain consistent with a fractured rib. So they have to look at all these details, and they have so many things they have to look for that it makes it harder for them to focus on small details that are very, very important. And so when I gave my explanation, I said, I look at all the films in all my patients, and I always look at what the radiologist's interpretation is. And in 2/3 to 3/4 of the cases, the radiologist's opinion and my opinion agree. And so we don't have a problem. But in the other cases, 1/3 to 1/4, we do have a disagreement. And of course, when we have a disagreement, we get follow-up studies to determine what's actually going on. And subsequent events, including these follow-up studies, show that my interpretation was correct 90% of the time, and the radiologist was correct 10% of the time. But that's because my interpretation is based on a plethora of clinical information that the radiologist doesn't have.
Understood, doctor. We do have two more. What is a toxicologist?
toxicologist analyzes poisons.
Okay, and do you need to be a toxicologist to figure this case out? How's that?
I think it was fairly obvious. Nobody's searching for whether somebody smuggled in heroin.
Last one, doctor. What is an infectious disease doctor?
Infectious disease doctor studies infectious agents, viruses, bacteria, fungi, protozoa, all things infectious.
Do you need to be an infectious disease doctor to figure out this case?
No?
Why not?
Well, I don't think anybody disagrees that the patient had COVID. And the decisions made on the COVID therapy, in my opinion, didn't make any difference in the outcome.
There was some discussion with counsel for Dr. Shokar about metabolic acidosis and when it appeared in your report. I just wanted to be clear, the overdose situation that you described today, when did that appear?
I think that's in the first report.
Yeah, is it in the second report too?
It's in the second report too.
What about the third report?
And third report too.
Do you remember discussing metabolic acidosis in your deposition?
Yes. So you want to know which one?
Sure, do you know?
Right. So the first deposition, the hospital attorney took up all the day, the entire day, and the attorney for Dr. Shokar had inadequate time to ask me questions, and he ended at a point, and we couldn't find the lab in the chart for him to properly ask the question he wanted to ask. So we came back to the second deposition is when I got a chance to finish his questions. And he was asking me about the blood gases, and he was asking me about, he put forward a hypothesis of why it would have been beneficial to give morphine when it was given. And he asked me, would there ever be a reason, would there be an advantage to decreasing the respiratory rate from the 50s? And my answer was, well, it would depend on why the respiratory rate was in the 50s. And if the respiratory rate was in the 50s for a metabolic acidosis, you would certainly not want to do that. So actually, the attorney is the first person who gave me the idea that the metabolic acidosis was a key part of this case.
Gotcha. There's been some discussion about drugs being given in an emergency. And I think the discussion was around consent and what happens in an emergency with consent. And I think you said that sometimes in emergent situations, there may not be time to get consent. Do you remember that?
Yes.
Okay. So if there's an emergent situation or emergency situation, can a physician just give whatever drug they want, or does it still need to be an effective treatment or a beneficial treatment?
Well, it has to make sense.
Yeah.
But you know, if a physician chooses something that a reasonably prudent physician would do in a similar circumstance, the fact that they had not obtained informed consent would not prevent them from giving the drug. So, you know, an example here, if I had been taking care of this case and I was.
Objection, Your Honor, may I approach?
can try to re-ask it.
Dr. Burdine, instead of knowing what, specifically you would have done in this situation, instead I'd like to know what a reasonably prudent physician would have done.
So a reasonable and prudent physician would have recognized the hyperventilation as a sign of metabolic acidosis, and they would have wanted to give bicarbonate and naloxone to try to resuscitate Grace, possibly also giving norepinephrine and dopamine. And the fact that they had not been able to get consent from the parents because you were now in a life-threatening situation that was imminent, you were looking at imminent death, you would have been permitted to do that, and it would have been within the standard of care, even though you had not obtained informed consent.
Dr. Burdine, what was the last opportunity that Grace could have been saved?
So certainly prior to the morphine, I think there's no question, had proper management been given, she would have been saved. Following the morphine, it becomes harder. But again, I have seen cases where naloxone reversal of morphine is near instantaneous. So even if a few minutes later, because she got the morphine at 1834, and she died at 1927. So even in the last moments, it is possible that the naloxone would have bought enough time for you to take other measures and save her.
No more questions, Dr. Burdine. Thank you so much for coming in.
Anything else, Attorney Frankowiak?
Doctor, can you state to a reasonable degree of medical probability that the administration of naloxone would have saved her life?
Yes.
Sorry, Doctor, rather than waste your time trying to get the microphone all plugged in and everything like that. I just want to ask you, I got a couple questions to follow up on your commentary about the deposition. How long did you spend in medical school?
4 years.
How long was that?
I did a little bit unusual program. The normal path would have been 3 years of internal medicine, 2 years of pulmonary. I did 3 years of pulmonary and 2 years of internal medicine.
Mind about
5 years postgraduate training.
4 years of medical school, 5 years residency training, 46 years of practice,
Yes,
almost 2 years with Grace's medical records.
I'm sorry.
You had Grace's medical records for almost 2 years.
I guess so.
And your testimony is that the questioning of a distinctly average trial attorney without a single day in medical school is what got you to thinking about metabolic acidosis. Is that your testimony?
That's what I said.
Okay, thank you, doctor.
Anything else, Attorney Flater?
I do actually just need to ask one more question.
Yeah, go ahead.
Doctor, we've talked a lot about, I think, not this question that you just had from counsel from Dr. Shokar, but when Council for Shokar, Dr. Shokar did that just before. We were talking about different sedation levels, and I think you had talked about earlier in the day the idea of a RASS, RASS score. Do you remember that? Okay. On the day of October 13th, based on your review of the records, what was the target RASS score?
As best I can tell, they did not have a target.
If there's no target, how does someone know?
They
How
have
much-
no basis for titration.
Okay, that's all the questions I have for now.
This is the time for the members of the jury to ask questions. So just a reminder, use full sheets of paper. And if you could put on your paper, your juror number. And if I could just get an idea by a show of hands, how many jurors are going to ask questions? So I see 4 hands, okay. 5.
Yeah, I got it. So there's not a 38. You have a list of your exhibits. Marking as exhibit number 523, the questions from juror number 386.
43. Council, I'm going to ask, as the letters or questions are still being circulated, if you can get exhibit number 43 ready to be pulled up on the screen. Plaintiff's counsel. Okay. Is exhibit number 524. The questions from juror number 1989. Exhibit number 525. The questions from juror number 262. Exhibit number 526. Questions from juror number 1989. Exhibit 527. Questions from juror number 587. And exhibit number 528 are the questions from juror number 2495. All right, so Doctor, just a few questions. I'm going to ask if plaintiff's counsel could pull up exhibit number 43, because this first set of questions, I think, deals with that. And I don't think that's the right exhibit. The title volume. The respiratory therapy flow sheet. Okay, that's the right sheet. And then if you could focus in on the lines that the doctor focused on before. And so I'm going to read you the question, doctor, and it says, can you explain tidal volume again? Not sure if the higher or lower numbers are better. Example, 4 p.m. SVT was 696, 641 SVT was 676. I'm just reading to you what the juror asked. And so maybe if you could just start and explain that again with that exhibit up there, please.
Sure. So tidal volume, the way it's measured is using the spirometer, and the amount of mouth and breathing in and out. And it says take deep breath in, blow it out, and there's a device that measures air moving through the device. Now, the technicians in this paper are using something similar, but especially when you have that state, you can't say take deep breath in and they're just measuring how much air is coming out with each breath. One of the devices used to do this is called Wright's barometer. And so the tidal volume is at the end of inspiration. So at that point, you've got a number up here. And then at the end of your exhalation, you got a number down here. The difference between the two is how much air you exhale. So the tidal volume for each breath is how much air was exhaled for each breath. So normally, higher is better. And in this case, at 4 p.m., the 696 is higher than the 676. So in this case, even if the intent was to have deeper breaths by lowering the rate, it didn't work out that way. The tidal volume was also decreased, and that's usually the consequence for it.
Thank you. Next question is, in your opinion, was Grace in an emergent situation when she first came to the hospital and was prescribed Precedex?
No. So when Grace first came to the hospital, in the emergency room, all she required was 3-liter nasal cannula, and her oxygen saturation was anywhere from 93 to 97% on 3-liter nasal cannula, which can be delivered at home. The problem for Grace is the cannula, the tubing of the cannula was falling off of her ears, so she couldn't keep the cannula in her nose. Now, there are probably ways that that could have been gotten around, a bandana or a scarf around the head to secure the tubing. That would have been one way to do it, in which case she could have gone home with just nasal cannula O2, and then you see how things go. By being at home, she's less likely to be agitated. She's in her usual environment, and if things go well with the nasal cannula, she probably doesn't require any additional therapy.
Your answer is no?
Um,
It was not an emergent situation?
No, her arrival at the emergency room was not an emergent situation. The reason they went to the ER is at urgent care. She was advised to get a CT scan to rule out pulmonary embolism on the basis of a blood test. And the CT scan showed the abnormal lungs of COVID, but she did not have a pulmonary embolus.
The next question is, do you believe it would have been helpful for Grace to have been intubated?
That's a very good question. I can see why the practitioners thought about intubating her. And would it have been better? The problem was there's a lot of misinterpreting of data going on. Again, I think things would have turned out fine if she had gone home from the ER with the 3-liter nasal cannula, and then you wouldn't have had any of this discussion. However, it's actually a question that's out of our hands because the medical power of attorney said no, and that decision is final. Now, as a practitioner, you can try to persuade them that it's in Grace's best interest to be intubated. There's nothing wrong with trying to persuade them, but the power of attorney has the final say on the matter.
I'm not sure if he answered the question, and all of that is good information, but do you believe it would have been helpful to Grace to have been intubated, regardless of if the power of attorney said yes or no?
Okay, at what point in time could the person who asked the question answer?
They didn't, so why don't we start with on October 13th?
Oh, on October 13th, would an intubation have been helpful? In the absence of identifying the metabolic acidosis as the culprit, then intubation would have led to a blood gas, in which case the metabolic acidosis would have become obvious. So I think on the 13th, yes, it would have been helpful.
What about on the 12th?
Helpful. I'm not sure in what way. You would have improved some numbers, but you would have made other things worse, and it wasn't necessary on the 12th.
Questions? Or
Yes, unless you want to ask it, if you want to go on that one, since you're on it, we'll let everybody kind of finish that one. Go ahead.
okay, doctor, I think what you just said was the ventilator would have been helpful on the 13th because it would have led to a blood gas. Is that
Yes.
okay? And then the blood gas would have caught the metabolic acidosis.
Yeah, you wouldn't be able to miss it anymore.
So I want to be clear here. What you're saying is the value of the ventilator on the 13th wasn't necessarily it's ventilating,
Right. It wouldn't have necessarily have been, and of course, it depends on what time we're talking about. It depends on what time.
It was, sorry.
Would a ventilator have been helpful at 1900? Absolutely.
That would have been 7 p.m.
Yeah,
Okay, and that would have been
absolutely.
after morphine and the
Right.
rest of the drugs. Okay. But prior to that, it would only been helpful to the extent that it would have led to a.
It would have
blood
led to the
test.
correct diagnosis.
Okay, I understand.
Attorney
That's-
Frankowiak? Any thoughts on that one? Okay, so just continuing on then with the jurors' questions. Are the exchanges between doctor and patient or doctor and power of attorney mentioned in the doctor's notes in this case?
The content of them, for the most part, is not. There are vague statements that discussions have occurred, but the content is not mentioned. So we have to determine what content was there and was not there from testimony given by people involved in the conversations.
The next subcategory of that question is, if yes, is the subject of this exchange written in those notes?
I'm sorry, what, if what?
Yeah, so if the answer is yes, that they are mentioned in the doctor's notes, is the subject of the exchange between doctor and patient or doctor and power of attorney written out? And I think you've answered that sort of, but.
Right, so at best, they're incomplete. Some things are talked about. For example, one of the things that is discussed between physician and power of attorney is Grace's prognosis or Grace's how things are going. But there is no mention whatsoever in any progress note of a discussion about Precedex.
Are you familiar with the frequency of a breach in the medical standard of care?
The frequency of breach?
The attorneys have agreed that that question is going to be withdrawn by me and not asked. So the next question is, and I'm going to try to, I'll just say exactly how it's written here. DNR order should be signed by patient or power of attorney. But was this done in time of COVID?
That's a very good question. So DNR orders can be obtained in multiple ways. You can have a discussion of the DNR situation. The informed consent discussion can say take place in the patient's room. In that case, absolutely, the note or form should be signed by the patient or medical power of attorney. Now, however, you can also have these discussions over the phone. If it's done over the phone, you can't get a signature from the patient or medical power of attorney. And in that situation in particular, the witness is extremely important.
Do you remember testifying this morning regarding a hole punch that was on one of the documents? And it blocked out a date?
Yes.
Okay. I believe your testimony was you didn't know who had done that or the circumstances, that it was either whited out or hole punched. Is that correct?
That is correct. To me,
Let me just maybe just slow you down. But you're comfortable that that's October 13th because it was in order with the other dates and it makes sense with everything else that you saw?
correct. The records in general are from most recent to most distant in the past. So it would have been logical for the 13th to have been the first page. Then following the page with the date that's not clear, we have the report from the 12th, and we get the report from the 11th. Those numbers are clear. The report from the 10th, et cetera, et cetera, et cetera. So it becomes fairly clear that the reports from the 13th. And also, if you look at the times stopped consistent with Grace's death.
And I think there's a stipulation, and the attorneys can correct me if I'm wrong on this, but there's two parts of that. Is I don't think anybody in this case is suggesting that anything was done intentional or to try to change something. Is that accurate, counsel? It is accurate. Defense agrees. And then I believe everybody agrees that that date is actually October 13th because of what this witness just said, that it lines up with everything else. Is that right?
Yes, agreed.
Okay, so Attorney Frankowiak. Okay, so jurors should understand that on that exhibit, that's October 13th. Everybody's in agreement with it, and it was just a hole punch. It was done unintentional. Is that a fair stipulation?
Yes, Your Honor.
Yeah, with respect to that record, which is what the question was. Okay, so then the next question is the following. Do you have knowledge of Grace's food intake from October 7th to October 13th?
Yes, there is mention. There were concerns about whether she was getting adequate oral intake. Grace is on a BiPAP device, and the mask covers the nose and mouth. And there were difficulties getting her to eat. Whether those difficulties could have been overcome had other methods been used is debatable. Certainly when the nurses tried to remove the mask for short periods of time and feed her, say with the nasal cannula in place of the mask, her oxygen levels dropped very quickly. If you're trying to feed somebody like this, it's very time consuming because you can have a situation where you take the mask off and the person has one mouthful and then their oxygen level drops and you have to put the mask back on. So it may now take 5 minutes to recover. And so you have to have somebody who has the time to spend 5 minutes per mouthful. And the only candidate for that job is going to be a family member.
Do you know why the feeding was stopped and when it was stopped?
I'm sorry, was what?
I'm just gonna read to you what it says. So still talking about the food intake and the feeding. So the question is, do you know why feeding was stopped and when it was stopped?
I don't think the feeding was intentionally stopped. I think particularly after the father, Scott, was evicted, it became impractical because there was nobody who had the time to do it.
Do you know whether there was any nutrition given to Grace in the IV that was in her arm?
They did not try something like TPN. You can give glucose solutions, but that has very limited benefit. TPN has its own set of problems and can be very complicated. But the answer to the question asked is inconsequential amounts of calories went in by the IV.
The next question is, what reason was given for a feeding tube when nutrition didn't seem to be a concern prior to October 13th?
I think this is a very good question. And in fairness to the practitioners, the nutrition was a major point of concern of the father, Scott. He was worried about it. And so there were discussions about how they could get around that problem. So I think the idea of a feeding tube was a legitimate one to alleviate what was a major concern by the father, Scott. However, the timing is a little bit more questionable. Going ahead, in my opinion, going ahead with the feeding tube and all the trauma involved after you've already made the patient a DNR does not make a lot of sense.
Do you want to say why?
Right. So it's Nurse McGinnis writes a note at the time the feeding tube. For one thing, they needed to give Lorazepam in order to attempt the tube. They put the tube in. It was quite painful for Grace. Her oxygen level, because they had to take the mask off to put the feeding tube in. The oxygen level dropped, I believe, in the 50s, between 50 and 60%. So it was a very substantial drop in oxygen saturation for the purpose of putting in the feeding tube.
And then the next question, and it's two questions sort of in one, so I'm just going to read both of them and then you decide how you know, it's best to answer them. Can you explain exactly how you believe the Precedex caused metabolic acidosis? Was it due to the published adverse effects of hypertension and low heart rate associated with this medicine?
So the specific hypothesis advanced by the questioner, hypertension, no, that was not the cause of the metabolic acidosis. Metabolic acidosis is one of the known adverse events of Precedex, although it's very uncommon. In some series, it's only 1%. In other series, it may be as high as 3%, but it's uncommon, certainly far more uncommon than bradycardia and hypotension. The two things most likely to cause the metabolic acidosis in Grace related to the Precedex is one, hypotension. So hypotension results in a drop in cardiac output. All of the cells in the body are getting less blood flow. It doesn't matter what your oxygen saturation if you don't have adequate blood flow. your cells will be starved of oxygen and they will start generating lactic acid. The second has to do with the regulation of the distribution of blood flow. Precedex affects certain types of nerves, and the neurotransmitter for those nerves is norepinephrine. And one of the kind of secondary effects of Precedex is the reuptake of norepinephrine following discharge of nerves is interfered with. If you don't reuptake the neurotransmitter, the nerve can't fire again. And some of these nerves are necessary to constrict blood vessels to distribute blood away from areas it's not needed to areas that it is needed. So something that you've all experienced, after you eat a big meal, your body distributes a great deal of blood flow to your stomach and intestines. And in between meals, it's diverted away to more important areas. If you are exercising muscles, those muscles get far more blood flow than they got when they're not being exercised. Now, your brain is always getting a lot of blood flow, but it's fairly constant. Your heart is getting a lot of blood flow even when you're not doing much, because the heart's always pumping, even when you're not doing much. Of course, if you're exercising, it's pumping a lot more, and now the blood flow to the heart has to increase. Another organ that's very important is the liver. And depending on whether the liver is active in detoxifying something, you'll require more blood flow to it. And another area that's very vital is blood flow to the kidneys. And how much blood flow to the kidneys depends on a lot of things, but it goes up and down. If blood flow to the kidneys is inadequate, you have a problem called renal tubular necrosis and acute renal failure, and it can be fatal. So the distribution of blood flow is extremely important. You know, the amount of blood going to your skin is often not a big deal. And if you have other vital functions going on, your body will distribute blood flow away from the skin to the vital area. And that's why when you get in a borderline situation, your skin gets cold. And if it's cold enough, you can be in shock.
Okay, thank you. Those are all the questions from the jurors. If your questions did not get asked, I've made a legal determination that they're not appropriate for this witness. They may be later on with other witnesses who are coming in to testify. So you can try to ask those again if you get the right witness on there or on the witness stand. But are there any follow-up questions from the jurors based on those questions and answers? There are none. So then Attorney Fighter, any follow-up?
No, Your Honor. Thank you.
Attorney Frankowiak?
Very briefly, Your Honor. Doctor, there was, well, one series of questions about feeding. There's nothing in the records to indicate that Grace was taking 5 minutes to eat one bite of food. True?
No, there is stuff in the record indicating that. There are plenty of notes indicating how difficult it was and how much her oxygen would drop when they were trying to feed her. Now, does it indicate 5 minutes? No, but whether it's 5 minutes or 4.5 minutes is pretty immaterial.
Absolutely. You recognize that when they tried to feed her, her oxygen saturations would drop because the mask was removed for the purpose of doing so. True?
So when the nurses tried to do it, they had considerable difficulty, and I certainly sympathize with the difficulty that they have, and I don't fault them for their efforts.
Okay. And your statement that every bite took 5 minutes is a number you're pulling out. It's not something you saw in the medical records. True? Just that comment.
Correct.
Last thing I have for you, Doctor. Grace did have a family member present with her, either her father or her sister, with the exception of the period from the time on the 10th when
when her father was removed until approximately the afternoon of the 11th when her sister was there. True.
Yeah, that's over 24 hours.
Okay.
I
And
thought
the-
there was a second stint where,
Yeah.
Second stint too.
was that what you were just gonna add? So there were two stints,
Yeah.
right?
Right, I'm talking about from when he was removed until her sister got to the room. And the records, you recall, the records do indicate that there were several notes where it was the communications were made with the family on the afternoon of the 10th, and in those communications, efforts were being made to feed Grace.
Yes, there were communications about feeding Grace.
Okay, thank you, that's all I have.
Attorney Guzzi,
Nothing further.
Attorney Fleiter,
No, Your Honor, thank you so much.
any follow-ups, questions from the jurors? Okay, Dr. Burdine, you may step down. Thank you for your testimony. And you are free to leave.
And Your Honor, thank you for your latitude in letting me use the stick and pointing things out.
We're going to be completed for the week. I'm going to stick around with the attorneys to try to make sure we spend the rest of the afternoon, get ready for next week. So I hope that the time this morning worked out well. The feedback I got from the bailiff is it worked for you guys and that's sort of what you prefer. So we'll do that same thing. If you can show up on Monday morning and do the same way you did it this morning, and we'll try to get you in here, at 8 o'clock or 8:05, shortly after 8 o'clock. Thanks for a good week. Notebooks stay in the jury room. Don't take those home with you. And remember, no contact with anyone. Have a good weekend. All right, everyone may be seated. This is a hearing outside the presence of the jury. Couple things with regard to the letters or questions from the jurors. First off, we had a sidebar. During that sidebar, we talked about the breach, or the question specifically says, "Are breach of medical standard of care often happen? If yes, are there statistics about it? How was it in time of COVID?" And so what I did is I took those questions and Attorney Guzzi, you objected to the first two of those three. But I started the question by saying, are you familiar with the frequency of a breach in the medical standard of care? So I changed around a little bit to see if he had a foundation to answer that. And I explained that during the sidebar because Attorney Administrator, you said you didn't remember the word frequency, and it was often. I changed it to frequency. We talked about the fact that I wasn't going to allow statistics or him to testify about statistics, but at the end of the day, Attorney Administrator, you said you're just going to withdraw the question to avoid what Attorney Guzzi thought was just plain error. Is that fair representation of what happened?
That's exactly what happened, Judge.
Attorney Guzzi, you're good with that? And Attorney Frank, and I think I also said I was going to ask it again, but you said not to. Okay, and Attorney Frankowiak, you're good with that?
Yes, Your Honor.
Okay, and then I don't know if you knew, but I did not ask two of the questions on Exhibit 527. It looks like Attorney Guzzi, you objected to one of them, and that was this set of questions marked as follows. Is it normal for multiple doctors separately to care for one patient in ICU that hand off a patient to many doctors in 1 week? What is a normal number? I did not ask the next set of questions, which was objected to by you, Attorney Frankowiak. Well, maybe, was it you who objected? Okay, so it would have been Attorney Frankowiak, and it says, do the first or second doctors do follow-ups with later doctors, or do later doctors follow up with earlier doctors? Did this happen with Grace? And the objection was foundation, and I thought the same thing. I went back and as he was answering the questions, I went back to his original opinions, and he didn't offer any opinions about the number of doctors or nurses or the communication between doctors or nurses. So my thought was any answers that he's going to give would only lead to opinions that there was something faulty. And that wasn't part of his, any of his reports.
Yeah, we're okay with that, Judge.
Okay, and then I figure you can, if it is an important issue, you can talk to the doctors and nurses when they take the witness stand about how they communicated. Do that, yes.
I just wanted to, doesn't matter, but my, I think the first two questions, why I checked the foundation of sound like all hospitals. And so I guess it was the foundation for all. We'll be talking about.
Okay, all right, exhibits 523 through 528 then are gonna be received. Those are the jury questions. We had one sidebar during that session. Attorney Fleiter, you had asked the witness a question, and he was starting to give an opinion about what he would have done, or if he were the treating doctor. During the sidebar, Attorney Guzzi and Attorney Frankowiak, you said that that wasn't appropriate. I agreed and said he could testify to the standard of care of what a reasonable doctor, reasonable and prudent doctor would have done. And so I sustained the objection, and you went ahead and asked it in the way of standard of care. So anything you want to
That's
say
correct.
regarding that sidebar?
That's correct.
Attorney Frankowiak,
Nothing, Your Honor.
Attorney Guzzi. Okay, so I anticipate that sometime on Monday or late in the day on Monday or on Tuesday, you're going to be resting your case, right?
That would be our hope, Judge.
Okay, and then I anticipate that there's going to be a slew of motions by defense. More than one. Okay, and I expect that it's going to take some time. So in an effort to, reduce the time then, as well as for me to be able to utilize the weekend to think it through, I'm interested in understanding in a non-argumentative way, and I don't know who wants to take the lead, what the plaintiff thinks has been established. What does the verdict form look like, given what has happened this week?
Sure, Your Honor.
Okay.
And I guess I'll address, I think the biggest concern is the battery claim. So that's where I'll start. At the final pretrial.
Yeah, and I have a different question, if you don't mind. I'd like to have you tell me what you envision the verdict form is going to look like. I have your one that you submitted a month ago.
Sure.
But what I'm interested in is I just want to get an image and then tell me where the battery fits within that.
I'm probably not the best
Okay.
to answer that question.
So I don't know how you guys do things, but my thought is, because my role is different than yours. I don't want argumentative type approaches here. I'm trying to figure out the verdict form. And I have a whole thing, sheet here listed, which is kind of what my summary of it would be, but I don't want to argue for you and I don't want to argue for them. And, the bigger question is, how does it all fit within each other, given what has happened? And if you're not prepared to do that now, then I'd say let's not waste time doing it. But I'm going to continue to think about it. Okay.
I don't think it changes a lot when Mr. Fleiter passes me on the verdict form. If this is about the form of the verdict, the facts that he brought up about the battery, he can speak better to that. But I don't think the verdict form that we proposed has any substantial changes to it. I think the evidence is there for the battery to go on, the negligence claim to go on, death to go on, and so it's not resuscitated. Change to that, I don't think there's any change in the question of damages. I don't think there's any change in the apportionment of liability.
Okay, so I think if I'm understanding your answer, negligence, wrongful death, battery, and DNR are the four categories you got to before apportionment of liability and damages.
Yes, and judge also that there are factual question for the jury on the do not resuscitate declaratory judgment.
Okay, so let's just start with the negligence. So I'm gonna go with your 4 categories. What questions fit within the negligence part that you've identified?
Number one, that is already on there.
I know it's on there. I'm trying to push you a little bit because if it was on there and I believed it, I wouldn't be asking these questions.
Was Dr. Shokar negligent in caring for Grace Schara at any time during her stay at St. Elizabeth's Hospital?
Okay,
Is that how you'd like me to address it?
is that still what you think the best approach is?
I believe so.
Okay,
If you answered yes to that question, was his negligence a cause of pain and suffering to Grace? If you answered yes to that, what sum of money would be the compensation?
okay,
Question number 4 comes,
we're still within negligence?
yes, Judge, we're still within negligence. I need to ask Mr. Fleiter, would question 4 about Allison will still stay within that?
Yeah, so I think given the developments and the, I guess, arguments that were made about the hospital subsuming the liability of the nurses, I think in regard to at least negligence, it would make sense on the verdict form to have a more generic question about negligence of any nurse and what damage that might have caused, given that the hospital has subsumed all liability for nurses, for negligence.
So question 4 had asked whether Allison Barkholtz in particular was negligent at all in her care, but Mr. Fleiter says I think that should be generally changed to just the nurses, staff. Were they negligent at all? And then go into if they were, was it a cause of Grace's pain and suffering? If that's the case, then are there damages?
Anything else under negligence?
I just wanted, if I may, Judge, you're proposing damage questions after each defendant? Or am I-
We're proposing different damage questions for Dr. Shokar for the hospital. So
I'm gonna ask you guys to give me your version after, I'm trying to get them to spell it out so I can,
I was just saying, I just wasn't sure, I wasn't clear. of what you were saying.
okay,
it would be one take with the that's what we would be proposing. Initially, it asked Holly McGinnis separately from Allison Barkholtz. It doesn't need to do that.
and then anything else under negligence?
Let me. As to the wrongful death, I believe that's also negligence.
It just, okay, so we're done with you started with 4 categories: negligence, wrongful death, battery, and DNR. Okay, so there's 3 categories, or, well, tell me where you're going next then. After the negligence of the nurses and cause and damages, then what's the next question?
Dr. Shokar cause negligence, the cause of Grace's death, not just the cause of Grace's pain and suffering, but the cause of Grace's death.
Okay.
And then it would be along those same lines, was the hospital's negligence a cause of Grace's death? If so, what are the damages?
Okay. And that takes care of the wrongful death part of it?
Yes.
Okay, and that takes us then to the battery?
As to the battery,
Am I right in saying that takes care of your first 2 categories?
yes.
Okay,
And as to the battery, this was the little difficulty here is which jury instruction would be given to go along with this verdict, or whether both jury instructions would be given to go along with the verdict. And the battery questions, I think, would depend upon which jury instruction or whether both jury instructions are given. And on this, I have to say, Mr. Fleiter factually answered these questions with that.
okay, so at this stage of the trial, what is the plaintiff's position with respect to the battery claim and I don't want to get into citing case law. I want to go with, tell me what the evidence is that justifies putting on the verdict form.
Sure, and I think I was beginning to relate back to our final pretrial conference where we discussed the battery claim. And there was a discussion about intent to harm, what that meant. And I think that one of the definitions or avenues for that was impairment of a bodily condition. In this case, and the, I guess, intent to impair a bodily condition. This case, we have established through the testimony of both Dr. Shokar and Nurse Holly McGinnis that they, through the use and administration of a medication, did intend to slow the hyperventilation of Grace Schara. Now, whether or not that was a harmful thing to do, I think is a question of fact that will have to be decided by the jury. I'm sure that defense experts will say that it was not harmful, but I think it's clear from the testimony today that our expert says that it was. And I think it's clear that it was an intentional thing to do. I understand that.
Stop you just for a second. You said something. It took me a second to try to process it. So tell me what you think your expert testified today that supports a battery instruction or a cause of action for battery.
Sure. So we established that this hyperventilation was a bodily condition in response to an oversedation overdose of the 3 different drugs. So you have the hyperventilation condition of the body. And then we established that, according to our expert, that suppressing this bodily condition or impairing the bodily condition is the direct cause of Grace Schara's death via metabolic acidosis and acidemia buildup, following the suppression of the respiration, i.e. the impairment of the bodily function.
Anything else?
Well, that goes to the intent to harm instruction. We're still sort of on a forked path here.
And if you go with the evidence that you just said you think has been presented during your case in chief, there's nothing to support one of those 2 prongs, right?
I'm sorry, you said there's nothing to support it?
Yeah, it sounds like everything you just answered me. And again, I don't want to put words in your mouth, but I was listening, and my understanding on your answer, if I'm understanding correctly, is everything had to do with impairing a bodily condition.
Correct.
Which would be only one of the instructions, not the other.
Well, yes. I mean, based on our final pretrial, we brought up the instructions. This was part of the intent to harm instruction that we discussed.
Okay, so are there any facts that you think have been presented by your expert or anybody else that would support the other instruction?
Well, yes, because the other one is very simple. It's just non-consensual contact, non-consensual offensive contact.
But tell me what you think that.
Sure. I think that we've established that these drugs were given without consent. Dr. Burdine established that the drugs required consent on the 13th. We did that at length today. I think that it's a reasonable question for the jury to decide whether being given potentially dangerous drugs without knowledge and consent is offensive. I think that's a reasonable thing a jury could find. And therefore, we satisfied the elements, or a reasonable jury could find that we satisfied the elements of that instruction as well.
So tell me what you think the difference is. Let's just pretend that the jury believes that there was an administration of drugs without knowledge and consent. That's what you said?
That's correct, Your Honor.
Is that the same or is that different than your negligence cause of action?
I think it's both. I think that was a negligent thing to do. Now, the informed consent is definitely under negligence, okay? But no consent whatsoever, I think, is a subsidiary of informed consent, but applies also to the battery claim.
Okay, so this is the first time I'm hearing you say this. So the informed consent fits under the negligence?
That's correct.
Okay.
I think we all agree on that.
So remind me then what the difference is.
The battery claim, the consent in regard to the battery claim is no consent whatsoever. If, for example, Dr. Shokar would have said, hey, is it okay if I give this morphine? And somebody would have said yes. And then something bad happens and Dr. Shokar didn't explain the risks or benefits under informed consent, that would be negligence. It was because there was consent, but it wasn't informed. So it's to a lesser degree than no consent whatsoever, which is, I believe, the testimony that we've established in this case so far. But
And when you initially answered the battery, you talked about the no consent, non-consensual contact for the administration of drugs on October 13th.
that's correct, Your Honor.
Referring to all three of the drugs? Or is it something else?
I think
I'm
it's
talking about battery only.
Yeah, it's more in regard to the Lorazepam and the morphine, because the Precedex was in an IV continuous, drip, you could say. So I think it's more in regard to the discrete administration of Lorazepam and morphine, although I think there's definitely an argument, not to get into it, but that the Precedex was also being administered without consent. It's not an event because it's just happening continuously. So it's a little more, it's not as clear.
Okay, so is it your position then that the battery cause of action, if you're talking about non-consensual contact in the administration of drugs on October 13th, you're referring to only the Lorazepam and the morphine?
No, I think we'd have to reserve the Precedex as well, Your Honor.
Mr. Administrator just gave you an elbow, so. Yeah,
He's the boss.
yeah, and so let me just,
You realize when we're at a high level discussion like this, I'm not gonna give a lot of input.
okay,
I'm kidding.
you're just giving the elbow when you,
Right, I've given the elbow because, I think that testimony by Dr. Burdine was very important relative to the synergistic effect of these three medications. So in order for us at this stage of the proof to restrict ourselves to the effect of only 2 out of 3 medications could cause us some difficulty. And I don't think
Yeah,
we're there.
and I'm not asking you to stipulate to anything, or you're not limiting yourself. I'm just realistically trying to figure out where you're at with the instructions, because ultimately when they make their motions to dismiss, that's what I need to decide. Okay. And then with the DNR, I don't know if this is back to you, Attorney Boylan.
So I think those questions regarding the do not resuscitate order should stay and should remain on the jury verdict. Your Honor had tabled, that's the first word that comes to my mind, you had tabled your decision on the DNR statute of 154.19, but there's still the common law DNR issue and the informed consent DNR issue about, I think the jury needs to answer, was a DNR order placed on our medical chart? Was that order placed with the family's authority, with Grace's authority, with the power of attorney's authority?
And by tabling it, I think on 154.19, I think what I said is it's probably going to go away if you guys can convince me by the end of your case. I gave you a heads up on both the lack of pleading and the fact that it doesn't apply in hospital settings. I think were the 2 items. But so let's just, right now you're asking that the verdict form would have 2 types of questions under the DNR, one having to do with statutory and the other dealing with common law?
Well, I'm saying that even if you were to take the statutory part of this out, then the questions are going to be different because the statute has some additional layers that have to happen. But under the common law, it's still a question, was the DNR order placed? Was the DNR order consented to? And did the placement of the DNR order cause a death? Even without the statute, those questions should remain on the verdict. And if the statute is in play, and I think Your Honor's summary of your tabling of the statutory ruling certainly correct. That's the summary you gave. Even if that comes in, then there's additional questions to ask. And if 154.19 is out, then we don't ask this question.
Okay, good. Anything else from the plaintiff then on sort of where you think, and this is not sticking you in, so if you do something over the weekend, you come up with a different theory or something, your hands aren't tied, but this is the best case right now.
Then there's other questions possibly about additional damages. There's going to be loss of society companionship from this.
Yeah, I'm not really I'm not worried about damages necessarily. I'm kind of bigger picture, and how this is gonna work out. Okay. I'd like to hear from the defense. Kind of the same approach. I know you're gonna be making motions and you don't think there should be a verdict form. Let's just get over all of that. And if there is a verdict form, what are you thinking?
Go ahead, Jason, are you gonna go?
Well, I mean, Brandy, you can, we kind of submitted the same basic form.
I noticed that.
The way it usually goes, usually informed consent is a species of malpractice, but I've seen it broken out into separate questions. There's a negligence question. I have not yet determined, in fact, how the hospital should be identified. As of right now, the only expert opinion is against one nurse on one issue for asking him or kicking him out of the hospital against Allison Barcodes as a nurse. So, as of right now, I don't know that putting the hospital was negligent, or was the hospital negligent, because that leaves it kind of up in the air in terms of what actually was supported. I think the wrongful death and negligence are combined. I think you're going to need damage questions, not for every, it's one pool of damages. It's not damages assessed to each of the individual, defendants. So I think, it's the negligence cause, and then the damages comes at some point afterwards, just with the permissible damages, rather than throwing the damages in for each of the individual defendants. And I also think, obviously, that I don't believe.
Well, let me just stop you for a second. Why would you only ask one damage question? So, so say, for example, later on appeal, one of those gets overturned. Why? So let me just throw an example. Right. So let's just say they find negligence on Dr. Shokar and on the hospital. Isn't it valuable to know what the damages are for Dr. Shokar in their opinion, with whatever the question is?
I've never seen it done that way, where there's damages attributable to each. It's always, you get the liability and the cause questions, and then there's one damage question at the end, and then it's just there. There may be an apportionment, if there's multiple people, then you apportion, and that apportionment question generally answers the way that the pool of awarded damages is apportioned. For example, 30% and 60% and 10% or something like that. And that's what usually breaks up the pool. If a pool of $100,000 is granted and all defendants are found negligent, and one is one is attributed 30% of the causal negligence, one is contributed 70% of the causal negligence, then that's the amount attributed to each of the people. Of that 100, that's what's attributed to each of the defendants who is found liable at the percentage that's assigned by the jury. That's typically the way it is. It's the assignment questions way it's done, rather than put a separate line under each one.
Okay,
so
that's one big difference. So, and keep going. Then
I would see like a negligence and cause, and there's probably going to be a separate one for informed consent and cause, just the way I've seen it done before in other verdicts. And see the next one. Then I think I have to take the position adamantly and without compromise that battery claim is. I'll try to keep the superlatives out, but I don't think it has been proven. And I think certainly we'll deal with that, but I don't believe there's anything to prove that there was any, number one,
no touching. Even the nurses, there's no proof that the nurse ever even touched. To administer these medications, it's given through a line. No touching of the body to administer these. Dr. Shokar didn't do it either, so
Can I
no.
just slow you down? Because I
Yeah.
don't really want to argue right now. I just want to
Sure.
think.
Sure. So I don't believe that there should be any questions at all on that
Understood.
question.
Let me just, so you said negligence and then cause, negligence and then cause.
Right.
And then damages, or then go straight to informed consent?
And depending if informed consent then would typically be next, like informed consent and cause. And then probably a damages question, no, or a comparison question if you've answered questions 2 and 4, or yeah, two and like 2, 4, and there's probably going to be a negligence or maybe a negligence question that would include Mr. Schara as well. So actually it would be negligence cause for the 2 defendants, then negligence cause for Mr. Schara. Then there would be.
Is there a cause of action for that? Is there a cause of action against Mr. Schara?
No, that would be, the law is that if there's any evidence, and it's not for me to say one way or another, in fact, I won't necessarily argue that, but if there's evidence that a reasonable jury could determine that anyone, whether they're a party or not, was negligent, they have to go on the jury on the verdict for the purpose of allowing the jury to apportion the negligence. And the jury can determine if that's the case. If the jury says, nah, it's crazy. No, he wasn't negligent.
So are you asking for him to be on the verdict form?
Well, I think we have to wait till the evidence comes in, because I mean, there's some evidence that a reasonable jury could certainly look that way. I mean, for whatever reason, not okaying the ventilator or however you want to look at it. There's any number of things that a reasonable jury could potentially do that. And then I think there's also somewhere in there is going to be the question for the 2 or the cause, the informed consent on the cause. And then there's got to probably be the comparison question always comes after all the negligence and cause questions are done. And then after that is the damage question. Now, here we have that, I confess to not really understanding the purpose of the last cause of action, the declaratory judgment. It's my understanding that there doesn't seem to be any award of damages attached to that. So, I mean, I would argue that probably should not be in the case at all, but if it is, I don't know, I probably would not come before the damages, because if there's no damages attached to it, you don't want the jury inadvertently awarding damages on those questions when they're not capable of awarding damages. I've never seen that kind of thing before go to a jury, so I'm not sure how to handle that declaratory judgment. I mean, that's a judge to handle. Declaratory judgment is always determined, in my experience, as a matter of law by a judge rather than putting anything in the hands of a jury. So I'm not really sure how to handle that, but I don't think there's any either allegation or law that would support an award of damages if depending on what they find on the declaratory judgment issue. It doesn't even ask for damages, I don't think. Right, so that's got to be taken care of separately from the above questions, so that the jury doesn't inadvertently award damages based on whatever the answers are given to those questions, if indeed they end up surviving.
Okay. Attorney Guzzi?
I agree with Attorney Frank Koyak on, in terms of the negligence questions, cause and the order. I agree with Attorney Frank Koyak on the battery. As far as the DNR and the declaratory judgment, I think if the court determines that 154.19 does not apply, I think the declaratory judgment action as it pertains to the DNR also disappears, because they're seeking a declaration that the DNR was entered illegally. If that statute is gone, then we're under negligence. I think we're in negligence territory. That's not illegal. And so I don't think there's a mechanism, if we're under a negligence paradigm, that the declaratory judgment can move forward. As to what the order is as far as battery, if the court determines the battery claim goes forward, whether that comes before negligence or not, I'm not sure. would suspect if the court allows the, battery claim, which is on the, in my opinion, the thinnest of ice, then I think there probably would be a separate damage question that would go with that. I don't know for sure.
Okay, so I have a question and something you had just said. Is it your position, Attorney Guzzi, that the DNR common law cause of action would be within the negligence question?
I do, because I think at that point it becomes an informed consent issue, and I'm not even sure that at this point whether specific questions would be necessary.
And I,
Make their argument in closing that, hey, you know, that conversation didn't take place, or it wasn't fully vetted, and that was negligence on their part. But I don't think there can be a specific finding of fact, because so what? I mean, it was either wrong or it was either negligent or it wasn't.
I think you've just hit on something that I've been struggling with all week, or maybe for several weeks, and it hasn't been addressed by plaintiff or by you, Attorney Frankowiak. And that is, you know, just assuming that we start with the Dr. Shokar negligence, wrongful death questions first, why would we not break out and ask specific questions? You know, and again, for example, was Dr. Shokar negligent in not obtaining informed consent for the DNR order? Was Dr. Shokar negligent for not getting informed consent for the medication on this day or that day? So that we get specific answers. So instead of just one negligence question, like I think everybody's proposing, I have a list of like 10 or 12 different things that I think are at play here that I've heard testimony. Again, I don't want to build cases for either side, but why wouldn't we ask the jury on each of those?
Why would we?
So that we know what their answer is, first of all, because we're never going to know what their answer is. If you just say, was he negligent? And they say yes. Then we don't know, was he negligent for doing the morphine? Was he negligent for what we just don't know what was the reason? And there's a lot of different things that have come in.
And my question is, why does it matter at that point? I will
Well,
say that in all the medical malpractice cases that that my firm has been involved in, and we've been doing this for I don't know how many years.
Right.
I've never seen a verdict in which specific questions about specific things are broken out. It's always, were they negligent? Was it causal? Was informed consent appropriate? Was, if not, was it causal?
Right.
And that's the verdict. I believe that's the verdict form. That's the standard verdict form.
The only question that's broken out separately from the negligence is the informed consent. Otherwise, they're just two separate sets of questions, but I've never seen one with the individual where 12 different issues are presented and they have to answer each one.
I think that would tend to potentially lead to the term escapes me now.
Well, let me just
I think that would totally confuse the jury, and I think that would be ground. I do think that you could have an inconsistent verdict.
I'm concerned about it being the other way, frankly. So let's just use an example. Was the hospital in breach of the medical standard of care for the overdose on October 7th? Yes or no? Next question, did the hospital violate the standard of care, or the doctor violate the standard of care not communicating that incident to the family after October 7th? Like, those would be two examples. And if the jury needs to get to 10 out of 12 for each question, one person might say yes on the first of those two and no on the second, and then they'll sign their name as to why they said no. And so they could find a breach in the standard of care on one and not the other.
They can't.
Well,
Here's why, based on the evidence. Dr. Burdine offered several opinions about standard of care, that there were breaches in the standard of care, but he didn't identify which physician. the hospital it cannot be a global, the hospital breached the standard of care. And he didn't identify the doctors involved. And even if he had it, that doesn't matter because they are not defendants in this case. So there's individuals not named as defendant. And this is my understanding. I haven't researched it lately, but defendants or individuals who are not named as defendants cannot cause vicarious liability to the hospital if that's the direction that you were going.
And maybe, again, I'm confused on the difference between the doctors and the hospital. And I didn't try to merge those two. But in any event, I'm just thinking, I'd like you to think through that. And again, I'm not convinced one way or the other. As I've said all along, if you guys are in agreement on a verdict, then I'm probably not going to interfere with it because I think it avoids both of you having appellate issues if you stipulate. But I can't imagine you guys are going to stipulate on a verdict. So I'm trying to figure out where you're at with it. And then I will draft. And if it's different than other medical malpractice, I'm okay with that. You probably, how often, Mr. Guzzi, do you have jurors ask questions?
Not very often.
Right, and look how good it's been. How many? I think each witness has looked at the jurors and said, "That's a really good question. It's a good question," and they're questions that they obviously want. They're going to help them get to results. Why do we not want them to get information that they think is important? And I understand why you guys might not want to, because you're trying to control your case and present it in your way. But if we're trying to get to the truth and have them get the information that's the truth, and my philosophy is we let them ask questions, and not every question was asked. And then when we get to the verdict form, I think we have a responsibility to try to ask questions that are going to prevent issues in the future. And while we have them in a room together, answer questions in a way that are going to be clear as to what those answers are. But I'm open to continue to listen. We're only partway through the case. So anything else today before we adjourn from plaintiffs? From defense? Attorney Frankowick, anything? Okay. Have a nice weekend. We'll see everybody at 8 o'clock or a few minutes before 8 o'clock on Monday. We're adjourned.